May I call Dr. Sita Lakshmi on stage? And may I request Dr. Manglesh Srivastava to chair the session, please?
Welcome Dr. Sita Lakshmi. She is presently Head of Department of Transfusion Medicine, St. John's Medical College, Bangalore. She is another pioneer in the field of pathology, a remarkable, outstanding and wise personality. Dr. Sita Lakshmi was awarded PhD from Rajiv Gandhi University of Health Sciences, Bangalore for her work on coagulopathy in malignant solid tumors. She is the recipient of the Dr. M.R. Parsarthi and Dr. A.V. Ramaprasad Silver Plaque Oration Award from Jawaharlal Nehru Medical College, Belgaum. She has over 50 publications in the index journals and has authored 2 chapters in the book. Her special interests are in fields of hematology and transfusion medicine and molecular diagnostic. Again, welcome Dr. Sita Lakshmi. Please continue.
A very warm good morning to all of you. At the outset, my sincere thanks to the organizing team for having me here once again to participate in this program. While the slides are up, after having heard Dr. Sukesh speak about the role of hematology analyzers, and in fact, he has highlighted several examples to say a laboratory can solely rely on the hematology analyzer and you don't really need smear morphological evaluation. So having heard that, I thought it's very important that we have a good performance evaluation of equipment, which is an integral part of quality control in any laboratory. And therefore, I'm going to be speaking on equipment performance evaluation. And unless this is so foolproof, we cannot rely on it. So what are the various aspects related to equipment performance evaluation is what we will be discussing. So primarily the discussion will focus on an overview of the evaluation of hematology analyzer with various aspects of quality control procedures, discussing certain issues concerning standardization of clinically important CBC parameters and the need for reference method as well as harmonization. So an approach to quality control requires that every factor in the instrument performance be appropriately controlled. The procedures that should be adapted are based on the use of control materials, correlation assessments, and statistical analysis that we routinely perform. So the role of an hematology analyzer is not just to speed up the workflow in a laboratory. However, it improves precision as many cells are counted. The cell classifications are based on measured objective properties of cells. Leukocyte differential counts are much more reliable, and therefore it provides clinician with more reliable data for proper management of patients. So the parameters that are available to us is a huge battery which includes nucleated red cells, immature granulocytes, different cell indices, red cell parameters, platelet parameters, and in today's diagnostic arena, digital imaging analysis as well. So, in fully automated equipments, control is required of the equipment to ensure that it measures up to the manufacturer's specifications and that it's correctly calibrated. There are, however, smaller labs which use semi-automated equipments where, assurance of technical skill of the operator, the reliability of the reagent and the test performance are equally important. Diagnostic hematology is based on morphology, making stained blood films. Not all laboratories are as advanced as CMC, and therefore we still rely on morphology. Therefore, the role of peripheral blood smear still plays an important role, and their interpretation requires professional judgment. So how to choose an analyzer becomes an important decision. Of course, we do rely on the instrument manufacturers to provide us a lot of information. However, peer-reviewed reports on comparative evaluations play a significant role in us deciding the choice of the analyzer. The There are several other factors that contribute to this decision making: the dimension of the equipment, information related to consumables, the ability of the instrument to be interfaced with the hospital laboratory information system. All these factors contribute to this decision making. And in addition to the repertoire of parameters that are available, the minimum sample volume, the data presentation, etc. So the new instrument should generate results that are comparable both in the units reported as well as reference ranges that are already in place in the laboratory. Of course, it must be evaluated with both normal as well as pathological samples before introducing it into routine lab practice. So that's when the term validation comes into picture. So when we talk about validation, it's establishing documented evidence that provides a high degree of assurance that a specific process will consistently produce results meeting its predetermined specifications and quality attributes. The data obtained in one laboratory on one instrument should give comparable results to that provided in another laboratory. This is very important. So the ISO 15189 states that the laboratory shall verify upon installation and before use that the equipment is capable of achieving the necessary performance and that it complies with the requirements relevant to any examination concerned. So the verification process should be performed. It should include precision, accuracy, analytical sensitivity, which means limit of detection, analytical specificity, including interfering substances, reference ranges, patient's correlation studies, limit of detection, carryover. These are the important aspects that we verify before the equipment is put into routine use. These objectives shall be investigated using well-defined protocols and their performance validated against acceptable reference method. And in the absence of these reference methodology, an on-market analyzer is used for comparison. So verification is the confirmation of evaluation performed already by the manufacturer. Verification should provide evidence that the analyzer can meet specific requirements at the test site. The performance attributes of the equipment should be obtained in the environment where it's going to be sited and all the staff who will be operating it. The reference ranges must be established by each laboratory before the analyzer is used for patient testing. So we know that the guidelines state that the responsibility of the instrument installation, setup, initial calibration using specified methodology essentially lies with the manufacturer. However, once this is achieved, the end user shall assess whether the manufacturer's claim on performance of the specific instrument also apply to the intended use criteria by the laboratory. And this process is called verification. So the parameters should be verified by the same procedure as that used for validation. We routinely use anonymous surplus samples that are available in our laboratories to determine the degree of precision and at medical decision values. That's very important because these can play a role about transfusion threshold decisions. So samples should be selected to ensure that extensive variation of pathological sample is included in the analysis, and samples in these situations, sometimes you could even dilute these samples to acquire a broad range of results. So when adapting a new hematology analyzer, it's important to compare this with the existing equipment to ensure that the patient's results are not affected. So the scope of verification depends on the parameters reported by the laboratory and the range of samples that are available to us. Of course, there are challenges unique to hematology, difficulty in establishing reference preparations owing to the relative instability of various hematological parameters. So when we talk about quality control procedures, in addition to instrument calibration, routine check with control samples, use of patient sample, preserved controls stabilized blood cells that are available to us, provided by the manufacturer, and statistical analysis, correlation assessment contribute to the QC procedures. So when we talk about the cell counting control, what are the characteristics that we look for? Of course, it should be stable, easily suspended, does not agglutinate. It should be, the rheological constants should be similar to the blood that is routinely used. The controlled particle size and shape contribute to these characteristics. with specific conductivity of the particles and the medium. So calibrators are essentially used which have stated values and are used primarily for equipment calibration, whereas controls are used for replicate testing within a laboratory on a day-to-day basis. So when to calibrate is another question, of course at installation and year after year, and as recommended by the manufacturer. There could be situations where we have major equipment breakdowns, or when quality control data show there is something seriously going wrong, and there could be a complete change of reagents. In these situations, it's important to recalibrate the equipment. The instrument manufacturer provides installation, calibration, and performance validation at the time of installation, and this is verified by the end user as a laboratory, and as I already mentioned, normal and abnormal samples to be included. The records of performance verification are to be maintained appropriately. Original printouts are necessary to be kept as reference, including record of downtime, breakdown, service response times, maintenance schedules, operator log. All of these are essential. Safety considerations do play an important role. It's also important to keep in mind that sample modes, when we have more than one mode, most of the equipments do have automatic and the manual mode. It's important to verify the performance of both the modes for all the parameters that we already spoke about. The reliability of barcode readers should also be monitored throughout the evaluation. So when we refer to precision, it is the closeness of agreement between test results when a sample is run repeatedly. It's obviously not a measure of accuracy. Imprecision increases in samples with lower cell concentrations as fewer cells are counted. It can be reported as SD and CV percentage. So an increased SD and CV percentage indicates an highly imprecise sample. Precision should be established for the entire reportable range of a parameter, and this would obviously include low counts, especially for hemoglobin and platelet, as I mentioned, at the transfusion threshold. Within run precision is also equally important. It's important to include normal and abnormal samples that we referred to. Linearity is another aspect that we have to perform. Ability to provide results that are directly proportional to the concentration of cells is what determines the linearity. So the question quite often that comes up is, what should be the frequency of linearity testing? So this is an example of linearity testing for various parameters. Sample stability is another important issue. Ability of a sample to retain a consistent value for a measured parameter over a defined period of time and within specific limits when stored under defined conditions is sample stability. So anticoagulated fresh whole blood should be processed within 4 to 6 hours after sampling if stored at room temperature. However, if samples are refrigerated, they are generally stable up to 24 hours, after which evidence of deterioration sets in. If you use pediatric sample or capillary sampling, there are other factors that need to be kept into consideration, especially if there is insufficient mixing or problems related to dead volume of the hematology analyzer, then the results may not be very accurate. So the closeness of agreement between results of a measurement and a known true value is what is accuracy. All the hematology parameters need to be measured for accuracy. So the reference method becomes important. For hemoglobin, of course, we do have a reference method, that the hemoglobin cyanide method, flow cytometric reference method for platelets as well as reticulocyte. Differential count, we still rely on morphological verification by two morphologists, count of 400 cell count, and that is still, I think it's still the reference method. However, we do understand that there are limitations. The slide distribution error, the interpretation error could contribute to this variation, and I'm sure there are better methods that we could rely on. So when we talk about comparability, regression analysis, correlation blind elements plots are used to assess the extent of agreement. Correlation coefficient is a measure of how well the data falls in a straight line. Closer the correlation, more linear is the agreement. The slope, the intercept, and the bias assessments are all additional useful information that we look to. So as was heard in the previous talk, it's important to look at the sensitivity and specificity of the flagging. This is determined by comparing whether the flagged or unflagged samples accurately distinguish samples with and without morphological abnormalities, based of course on morphological review. So the accuracy of flagging is determined for various clinically significant parameters. Sensitivity is important to identify all abnormalities, and therefore we produce accurate results. However, specificity is important to limit unnecessary microscopic examination and thereby increase the efficiency of the laboratory. So it's very important to have the striking delicate balance between the sensitivity and the specificity. So instrument flags play an important role. So you could have manufacturer control flags which are already available to us, laboratory control flags for critical decision making rules and critical ranges is incorporated by the concerned laboratories. There are several messages that are provided to us. For example, abnormal cells, red cell agglutination, platelet aggregation, and so on. So the laboratories using these analyses should create policies for slide review and manual differential count. Carryover is another important aspect that we should keep in mind, because this can erroneously result in a falsely high value in a subsequent test sample and leading to erroneous clinical interpretation. So the limit of blank refers to any signal that is measured that actually does not originate from that particular sample and a parameter of interest. Optimally, the background counts have to be 0. This is just an example to show that we quite often, if there is no proper background testing, you can have erroneous platelet counts. The next aspect that we need to discuss is the calculation of reference interval. So, as desired by the standards, it's important that each laboratory establish their own reference intervals. However, having said that, it's going to be a challenge, particularly in pediatric patients. So, published reference intervals and those provided by the manufacturers are quite often used by all the laboratories. Inter-instrument comparison is another important aspect. So, if a laboratory has multiple analyzers and different analyzers using different methodologies, inter-instrument quality control is important. This is to ensure that we don't have unexpected discrepancies between results generated by these equipments, resulting in unnecessary clinical intervention. So this can be done by running patient samples across the analyzers in addition to the routine quality control testing that we perform. So for intra-instrument quality control, QC samples on a daily basis is necessary. These are obtained easily provided by the manufacturer. So these are run after calibration of the equipment and periodically on a regular basis during testing with appropriate storage conditions. That becomes important. The next question is, are there pitfalls with the QC materials that are available to us? The manufacturer's target limits are often very broad. Thereby, subtle changes in the analyzer behavior can be missed. Therefore, it's recommended to adjust the target range after the laboratory runs several runs and measures its own mean and the target range. A benefit in using these QC samples, as we all know, is we can identify drifts using the LJ graph. So the daily controls, commercial control, patient control, moving average, correlation, comparisons, and policy for acceptability of QC testing, troubleshooting, all are various aspects as an integral part of IQC. So therefore, we should have policies and procedures, assign staff responsibility, establish control ranges, monitor control values, and develop procedures for corrective action. So this is something well known, so I'm going to quickly skip this. Yeah, so the important question, as I was just talking about in the previous slide, can manufacturers' stated reference ranges be used by the laboratory? Yes, the standard requires, as I mentioned, that the laboratory measure its own reference range. However, there is an allowance to use manufacturer ranges when the following conditions are met. The stated values correspond to the method and instrument used by the laboratory. The mean obtained by the laboratory reflects the manufacturer's stated mean, and the laboratory assures that the range is narrow enough to detect clinically significant errors. So manufacturer ranges can also be implemented if a test is used sparingly, infrequently, and that calculation of valid statistics may not be possible. In a setting where there is high reproducibility, the laboratory's range can be very small. In those situations, this can result in unnecessary repeat testing of QC, and because it's outside the laboratory range, however, it is within the manufacturer reference range. Therefore, it's important that manufacturer selection of appropriate range is a very delicate balance between these two spectrum, that provided by the manufacturer and that generated by the laboratory themselves. So we should also note that certain parameters like MCV, the QC material that we use, the MCV gradually tends to increase with time, the red cell values decrease, platelets values increase. This is because the cell volume increases, the RBC starts lysing and get counted as platelets, resulting in erroneous results. So QC should be evaluated, of course, monthly to ensure continued acceptable performance. There should be a QC policy for trends, bias, and shifts, and establish all this when calibration is required. So when QC goes out of control, it's important to stop testing and identify the problem. Do not report patients' results. There has to be a policy for troubleshooting when results go out of range. Retained patient sample testing can contribute significantly to a part of QC procedure. However, please note that these are additional approaches to IQC and not alternate approach. So performing duplicate tests on patient samples can add value. For example, if you can perform duplicate testing and determine the degree of variation, and none of the duplicate tests should differ from each other by more than 2 SD. This can be a very useful internal QC parameter. Moving average is another useful measure. Daily mean, of course, correlation comparison. Delta checks that we all rely on. It's important that delta checks could be crossed when there is pre-analytical issue or possibly clinical therapeutic interventions. However, delta checks, if monitored on a daily basis, play an important role. So automated reticulocyte, again 2 levels of control with at least verifying the manual performance once a week can add to our QC plan. So when we plan IQC, the size of the laboratory, number of specimens, whether the lab is a 24-hour lab, the type of equipment, accreditation requirements, all of these factors should be kept in mind. So these are the various QC tools that we just spoke about. So I would like to conclude the session by drawing your attention to certain important aspects. So CBC parameters that we use, not all of them have reference methods. So that can pose a challenge. MCV and other parameters, there is no reliable reference method. Platelet parameters, there are many pre-analytical variables that come into picture, so that can be challenging. There can be difference between 2 laboratories generating these results because different analyzers use different cutoffs and measurement methods contributing to the variation. So to summarize, the verification process of a hematology analyzer by an end-user laboratory involves issues with regard to pre-analytical and analytical phase, which should be standardized and controlled. Reference methods and standardization of CBC parameters will contribute to harmonization and more reliability on these results generated by the auto analyzers for clinical practice. With this, I conclude the session. Thank you.
Thank you very much, Dr. Sita Lakshmi. Dr. Manglesh, over to you for any questions, Q&A.
Thank you, ma'am, for a lucid talk. I think any questions are not remaining, but still, if any doubts, please.
Yes.
Ma'am will happy to answer.
Yes, I have a question. One of the, let me say, problems or is how we can control the transport of the samples from laboratories that receive samples from outside. And of course, the temperature can change. It's not sometimes room temperature, and can be sometimes 8 hours, 6 hours, 10 hours. And my challenge is that how you propose to we control this transportation of the samples.
Yeah. I think this is a very important aspect that control becomes important. I did not touch too much on pre-analytical aspects. However, having this question having come up, it starts with appropriate sample collection, how the samples are mixed, and what control is maintained during transport. So the temperature control, of course, especially in India as a country where you have regions with significantly high temperatures as well. So monitoring and transport is an important aspect. So temperature, how the samples are kept and how they are mixed after collection and appropriately transpose the volume, the ratio of anticoagulant blood, all this can contribute to the extent of variation that we will generate from the analyzer. So you have brought out a very important point, sir, the pre-analytical, especially when samples are received from different locations to a laboratory, can pose significant challenge because very many conditions we may not even be aware because we may not have even witnessed the site from where these samples are coming. So this can become this can contribute to erroneous results that we produce by the analyzer. Yes, thank you.
Yes, as a proposal from me is that when you realize that you are going to receive samples from a center,
Yes.
I recommend to emulate the transport, sending a sample collected in your own lab, sending to the half of the time that you need to arrive to this place and return to your lab and measure again. Because before to approve to receive samples from a center, I think some controls have to be done to evaluate really the changes and to realize if you have to transport it at 4 degrees with a special transportation boxes or not. And my second question is about the morphological parameters. For example, parameters that are not measuring directly and it's difficult to have a control that is the same, for example, IRF, IPF, morphological parameters from the graph that you cannot find any analog to emulate exactly a reticulocyte to be analyzed. How we can control that? And this is also another question.
So in this context, what I feel is we don't go by the results generated of a single parameter. Like sir was talking about in the previous session as well, hematology is in the context. So we look at it in the context of the case, correlating with other parameters, which can add value to reporting rather than go by the result of an isolated parameter. I think I would place a lot of importance to this aspect before we generate a result. But however, this can be challenging in certain laboratories where results are just, samples are fed into the machine and results are generated without this aspect. Having said that, lack of adequate clinical information that is received in every laboratory can pose a challenge if we interpret these results in isolation. This is what I think.
Thank you.
Any other question?
Dr. Sita Lakshmi, very good compilation of a quality system of lab. We have a lot of pediatric samples and finger prick samples. Now to do the quality control of those, you run the controls as a whole blood sample. What is your thought on the finger prick sample of calibration of your equipment and the validity of those results? First question. Second is on the inter-instrument manufacturers' level of platelet counts on the basis of the size of the platelets. Now we have many communities who have higher giant platelets. When they come to one analyzer, it gives 30,000, the other gives 80,000. Both are low, but look at the variation. It is the discriminators that these manufacturers are putting in their equipments. Should there be a uniformity in that as well? Two questions.
Ma'am, I think you have just hit on the nail. In fact, that's what my concluding session was. There is an urgent need or absolute need to harmonize the results generated because there are analyzers, all of them are good in their own way. Each of them have different methodologies of testing. But however, in certain clinical situations, we can have discrepant results because of these variations, and there is lack of reference methodologies that are available contributing to the problem. So you said it very right, and I agree 100%. There is an urgent need to harmonize and standardize. Till such time, I would think the answer to both your questions, I would still rely on peripheral blood smear, morphological microscopic examination of the smear till we reach that stage. This is my response, ma'am. Thank you.
Thanks, ma'am,
Thank you.
for a nice morning academic feast.
Thank you, sir.
I think this will help, especially to the younger ones who are freshers in the field of hematology. Thank you, ma'am.
Thank you.
Moving ahead, may I call Dr. Manoj Kahar for the next session, please, and may I request Dr. Sankar to chair this session.
He's a specialist in the transfusion science practice and has wide range of areas of work and an internationally known speaker. Sir, over to you for this talk on utility of reticulocyte parameters in hematology.
Thank you, Dr. Sankar, sir, for the kind introduction. And my special thanks to the organizing team of Mindray for this Cube 23, and my special thanks to Sama Madam for giving me this opportunity to be on the dais amongst the dignitaries. And at the outset, please let me be clear that this is a very basic presentation, and this is addressed to the fresh colleagues, junior colleagues who are coming into practice, and many of the senior faculties who are sitting here may not find this very appealing, but still we'll go ahead. So what we are going to discuss are utility of reticulocyte parameters in routine hematology. And the definition of reticulocyte is that the reticulocyte derives its name from the reticulum of RNA and protein precipitated by the fixation and staining that appears microscopically after treatment with supravital dyes. And the reticulum network or granules, they represent a precipitated rough endoplasmic reticulum with associated polyribosomes. And we have a very specific definitions for NCCLS, ICHS, which says that reticulocytes must have at least 2 blue staining granules, and this should be visible without fine microscope adjustment. So the granules have to be coarse enough, and they should be seen without fine microscopic adjustment, and they should be located away from the cell margin to avoid confusion with Hens bodies. So this is a very specific definition which has been given by NCCLS for reticulocyte. The benefit of this official definition is that standardization of the reticulocyte morphology, but this definition does not take into account the wide use of fluorescent dyes that we are using presently in measuring reticulocyte mRNA. So this definition is not addressing the fluorescent dye which we are using. Now we all know that there is an Helmier classification for reticulocytes. Group O is the nucleated erythrocyte, or we know as orthochromatic normoblast, and this is not included into the reticulocyte classification. Group 1 is non-nucleated red cells appearing with a dense clumped reticulum, and they comprise about 0.1% of the population of the reticulocytes in normal individuals. Group 2, if you see, they are extended network of loose reticulum. They comprise about 0.7% of the reticulocyte population in normal individuals. Group 3, if you see the figure there, scattered granules with residual reticulum network, they comprise 2% of the reticulocyte population. And group 4, scattered granules, they comprise 61% of the reticulocytes. So this basic Helmier classification is helpful when we will go to the concept of IRF. Now, there are issues related to microscopic reticulocyte count, and as we have discussed, the standard method is based on the visual detection of granules and RNA ribosomal networks stained by supravital dyes. But there are various sources of impression, and these impression sources are manual counting of reticulocytes, how many reticulocytes you count, how many RBCs you count to go for the reticulocyte count, including different procedures, staining variation, distribution variability for quality of blood film, intra-observer and inter-observer variations, inadequate number of cells counted. So all these add to the imprecision, and this is the reason why we have shifted to automated reticulocyte counts. And most of the manufacturers now, high-end instruments, they offer us the automated reticulocyte count, and the reason for this is the source of imprecision. Now the new methylene blue method and procedure described in the NCCLS ICH H44A2 guidelines still remains the recommended method for agreement correlation assessments when evaluating the performance of automated techniques. So even we have moved to automated techniques, the manual method is still considered as the method of choice when we want to compare the results. Now there are different manufacturers, and different manufacturers have different methods, they have the different dyes, and when you are using your instrument, you should be conversant with the method being used by the instrument, the dye which is being used by the instrument. So if you see, there are various instruments about the Beckman Coulter. Beckman Coulter has a series of instruments. Mindray also has a BC6800. I am using BC720. So you need to be conversant with your equipment, the dye which is being used, and how the instrument is performing. And this is a summary slide where you know which are the dyes used. And if you see the Mindray one, Mindray uses asymmetric fluorescent signing, and the technique which we use is SH cube. And these are the different instruments, what are the technology and what are the dyes being used. Now, as Dr. Sita Lakshmi said, we have to derive our own biological reference interval, and this is a big exercise because if you even see the one of the researcher, if you see here, he has derived IRF in different instruments, and if you see the IRF, BRI, all are varying. The same researcher has taken different instruments like Celdine, Janus, Pentra, SE9500, and if you see the IRF, they are varying. So you need to derive your own IRF, and it's a big exercise, and you need proper statistical calculations. And I would request that zone-wise we have to collaborate, and we have to come with our regional BRI. So you can have a regional BRI from West Zone, East Zone, or maybe North Zone or South Zone. And many centers who are having high workload, they can collaborate. We can take the help of the manufacturers, and then we can come out with our own BRIs, which will be useful for reporting this parameter, advanced parameters, because we don't get good BRIs in the textbooks, because they are novel parameters and they are not yet included in our standard textbooks. So we have to derive the BRIs. Now the first of the parameter which we report is the immature reticulocyte fraction. An internationally accepted term is to quantify the younger fraction of reticulocytes. So if you go to that Helmier classification, this could be the group 1, group 2. And some of the populations of high and medium stain intensity is our IRF. And I have given the formula also how the manufacturers, they calculate this IRF. And if you see here, the IRF is basically this high fluorescent and medium fluorescent. Even in that graph, if you see, the HFR and MFR, they are together taken as the IRF. Now, IRF, it is considered as an early marker of engraftment in bone marrow or hematopoietic stem cell transplantation. And several studies have demonstrated that increases in IRF are an indicator of engraftment that precedes other parameters like absolute neutrophil count, reticulated platelets, or reticulocyte counts. So it's a good parameter to demonstrate the engraftment. And in large group of patients undergoing allogeneic hematopoietic stem cell transplant from related or unrelated donors, IRF greater than 10% occurred 1 to 4 days sooner than ANC greater than 0.1 into 10⁹ per liter in most instances. And most of the investigators, they consider that IRF value greater than 10% is indicating an early marrow recovery. Then IRF is also a strong indicator of post-chemotherapy aplasia in children with cancer, serving as an additional parameter of impaired bone marrow function. Then IRF is also used by some researchers to see that it is an early marker of CD34 mobilization for peripheral stem cell harvesting to optimize the timing for stem cell collection for following growth factor mobilization or cytotoxic drug therapy. Then IRF increases have also been used to assess erythropoietic stimulation following erythropoiesis stimulating agents. Then IRF is also used in the diagnosis and monitoring of various anemias, and some of the researchers have used this ratio of reticulocyte count to IRF ratio more than 7.7 as a precondition to screen for hereditary spherocytosis cases. And Because IRF increases earlier than the reticulocyte number, it is useful in monitoring the efficacy of therapy in nutritional anemias such as megaloblastic or iron deficiency anemias. So these are all utilities of IRF. And this is a summary slide which tells us where IRF goes high and where the IRF will be low. Then second parameter which is being used is the reticulocyte mean cell hemoglobin content, and different equipments they label it differently. Some instruments they label it as CHR, some as Mindray labels it as reticulocyte hemoglobin expression, and some instruments also have the reticulocyte HB cellular, that is RHCC. And studies concerning iron deficiency in pediatric patients, they have demonstrated that measurement of reticulocyte hemoglobin content is helpful in identifying the iron deficiency before the development of anemia. So you are able to pick up the iron deficient stage before the actual development of anemia. Then there are beautiful algorithms which have been devised based on the CHR, and there are three parameters which are being looked into. One is CHR, second is the HCT, and then MCV. And this is one of the algorithm which is being published to detect iron deficiency in adolescents. And here if you see the CHR, your hemoglobin is not low, but you follow it with CHR. And if this CHR is less than 29, then you see the hematocrit age. Then depending upon the sex, again you give ferrous sulfate, follow up in few months. And then if you have CHR less than 29, consider thalassemia rate, more than 29, continue iron treatment. And if your CHR is more than 29, normal hematocrit, healthy person, low HCT, according you grow. So there are various algorithms which are being published which help us to use this particular parameter in early diagnosis of iron deficiency in adolescents. Then reticulocyte mean cell hemoglobin content, it is also useful in situations of functional iron deficiency and iron sequestration syndromes. And we know that functional iron deficiency occurs when iron stores are transiently unable to meet the demands of increased erythropoiesis, such as those occurring during erythropoiesis stimulating agents treatment. And iron sequestration syndromes occur in chronic diseases when iron is not available for erythropoiesis. And this is, as we know, because of high serum hepcidin level, which determine iron sequestration in the reticuloendothelial system macrophages. So macrophages, they don't allow the iron to be given to the bone marrow. And one of the major determinants of ACD is iron sequestration. So there are various guidelines, as Dr. Sukesh sir was also discussing, and the question was from the audience also, that there are various guidelines which recommend the use of CHR for treating those patients of chronic kidney disease. So you have the Kidney Disease Outcome Quality Initiative of National Kidney Foundation, then British Guidelines for Laboratory Diagnosis of Functional Iron Deficiency, and then the Agency for Healthcare Research and Quality. All of them, they recommend the use of CHR in the treatment, and they recommend a cutoff of about 29 picogram. Then there are various plots which are being published which help us to identify different erythropoietic states of advancing iron deficiency. And they are combining biochemical indicator for iron supply. So you have the biochemical indicator for iron supply, that is this STFR-F index. This is the biochemical indicator for iron supply, and you have the hematological parameter for iron demand. And based on these two, there are plots, and these plots give us the idea about whether there is a functional iron deficiency, whether there is a classic iron deficiency anemia, whether there is latent ID, or there is iron repletion. The only problem with this plot is the cost of the investigation. STFR and ferritin, if you combine, and also the CBC, the cost goes around more than 2,000. And this limits the use of such plots, only the cost. But this is a good plot which will help us to segregate all the 4 different types. Then reticulocyte hemoglobin is also useful in monitoring the efficiency of treatment in iron deficiency anemia. And as we know, the hemoglobin content and volume of reticulocytes, they increase significantly after intravenous iron therapy, reaching the normal values on day 3. And if you see, is one of this case, if you see, The CHR on day 0 is 23.3, then 25.3, then 28, 30, 31.1. So it increases, and simultaneously the reticulocyte volume is also increasing, 98.3, 102, 105, 119. And even on day 4, you can judge that the patient is responding to your treatment. And usually the clinicians, they do the CBC and they evaluate the response of therapy after say 10 days or 12 days. But this is a good parameter which will tell you whether your patient is responding to the treatment or not. And this is a very fast to detect whether your patient is responding to treatment or not. Now there are limitations in clinical utility of this reticulocyte hemoglobin content. And reticulocyte hemoglobin content is decreased in thalassemia syndromes, whereby the reduction in CSR seems to be correlated with the degree of impairment of beta chains. And in other microcytic anemias also, where you have some problems with congenital hemoglobin disease, your reticulocyte hemoglobin content will be decreased. Reticulocyte hemoglobin content will be elevated in iron deficiency patient with confounding megaloblastic anemia because of the higher mean reticulocyte volume associated with megaloblastics. So when you have a combination of iron deficiency as well as megaloblastic anemia, this particular parameter will be not of much use. Then your reticulocyte hemoglobin content, it is increased by drugs using transient or permanent macrocytosis, such as chronic hydroxyurea treatment in patients with sickle cell disease. And therefore, when you are going to use the CHR value, it must be interpreted in context of the patient's overall erythrocyte physiology, including knowledge of recent blood transfusion, iron therapy, vitamin B12 or folate deficiency, chemotherapy, and results of hemoglobin analysis. The last parameter is the reticulocyte cell volume. And reticulocyte cell volume is decreased in iron deficiency anemia and thalassemia syndromes, but reticulocyte count is usually lower in iron deficiency anemia, whereas IRF may be higher in thalassemia. Then reticulocyte volume increases iron deficiency anemia during iron treatment and decreases with the development of iron deficiency erythropoiesis, such as reticulocyte hemoglobin content. In macrocytic anemia, the reticulocyte volume is larger than that of the normal reticulocytes, demonstrating megaloblastic erythropoiesis. And as we know, treatment with vitamin B12 or folate induces a rapid normalization of the volume of reticulocyte, reflecting the efficacy of replacement therapy. So when you are replacing the therapy, this all newer parameters will give you that your patient is improving earlier than the routine what we use MCV or you take hemoglobin. They tell you earlier whether a patient is responding or not. MCR, this mean cell volume, has been measured in sickle cell anemia. Induction of fetal hemoglobin synthesis by hydroxy therapy was associated with increased hydration of sickle reticulocytosis assessed by MCVR. So when you start hydroxyurea therapy, the reticulocytes will be increasing in size. So automated flow cytometric analysis has led to a significant advance in reticulocyte counting, providing us various parameters like IRF, reticulocyte volume, hemoglobin content and concentration in reticulocyte. And IRF assesses reticulocyte maturation by the intensity of the staining that reflects the mRNA content. And IRF has been proposed as an early marker of engraftment in bone marrow or hematopoietic stem cell transplantation and bone marrow regeneration following chemotherapy. Reticulocyte hemoglobin content, it is useful in assessing the functional iron available for erythropoiesis during the previous 3-4 days, while reticulocyte volume is useful indicator when monitoring the therapeutic response of anemias. These are my references, and thank you everybody for your patient listening.
Thank you, Dr. Manoj Kahar, for a very elucidative talk on reticulocyte and the 4 different parameters which we can use. The baby of the hematology is the reticulocyte, you know.
We can go in other ways, sir. Reticulocyte is the mother of erythrocytes.
You can call like that. I thought of a baby because now I am a grandfather.
But if you say it can be a mother of erythrocytes.
This baby cries at the middle of the night and dumped into your hands. And I try to analyze and find out the reasons for it. One is probably he needs feeding. Second is probably he needs to sleep. Third is probably there is a stomach ache. And fourth, he's bored. He has to play. And when he wants to play, you start feeding. And when he wants to sleep, you start doing other things, it's not going to work. So like the reticulocyte, you exactly have to find out what exactly is wrong with it and then give the proper intervention as you have shown through the plots and algorithms. So it has thrown a very elucidative and elaborative talk. The paper is open for discussion and comments.
Yes, thank you for your talk. Very nice. And I would like to make a comment more
Yes.
than a question. You presented the plot, like the Thomas plot, classifying the anemias, and I like that more than the other proposals that says that only with hypochromia you have to give iron. And I think it's better to use CRP because if you have hypochromia, low CHR, high hypochromic red cells, low MCB, but CRP is positive, is high, I think we need to do ferritin before to give iron.
So in my slide, I had that CRP value also, and basically it is a inflammatory state, and that inflammatory state is leading to release of interleukins, and that interleukins is not allowing your macrophages to deliver the iron to the
Yes.
bone marrow. So CRP, ferritin, all are inflammatory markers, and they will guide you to determine the functional iron deficiency states.
Yeah, but
So
the point,
other biochemical parameters have to be taken in association with the CHR or reticulocyte hemoglobin expression.
yeah, but I like it, this plot because we don't have to forget the immunochemistry parameters that are very useful before to administrate iron.
But the problem with this plot in our country is the cost of the investigation is quite high, because if you take soluble transferrin receptor, if you take ferritin, if you take the CBC, it goes around 2000 plus. So it's a limiting to use this plot.
Okay, thank you.
Okay.
Yeah, any other questions? Sir, two things I have taken home from your your talk. One is that we should be aware of the various types of dyes which they use in each instrument, and it's very varied, and the techniques they use is also quite widely different. And validation, I am sure, has to be done. Second, of course, is the regional VRI which you have been suggesting regarding collaboration in this. I think that's also a very nice suggestion, and I request the House to take a positive response. on
So
this.
we need to have collaborations in the different areas of, and that to be the high workload centers have to collaborate and come with a BRI which can be useful for that particular zone.
I think that's a
And
very
if you see
excellent
the one of the slide I had shown, the researcher, one researcher, he has used the different instruments and he has got the BRI different for all the IRF.
Exactly. Exactly.
Okay,
Thank you very
everybody.
much, sir. Thank you.
Thank you very much.
And may I request Dr. Sankar to please again chair the session.
Kakar is currently working in hematopathology in CMC, Ludhiana. We heard Sukesh speak about him. And his work on spurious automated results, hemoglobinopathies and coagulation disorders especially is well known. Sir, over to you for spurious results in automated analysis.
Good morning, everybody. I'd like to thank Dr. Anil Handu, BLK, and Mindray for inviting me over. It's always a pleasure to come and listen to so many young, bright minds targeting new things to be thinking about. So after yesterday's show that we had on the stage and here, Dr. Anil Handu has kindly consented to give 2 terabyte hard disk to all of you. Only the offline attendees. Round of applause. Okay, that was fake news. I take back my words. So my topic is such. We are so fond of our analyzer. I can vouch for my analyzer. But sometimes there is an enemy within that we need to know about. We don't need to fight the enemy. The analyzer is our friend, our best friend. But we need to understand what it does for us. So what if to a patient who had, sorry, can't get the point to going, 1 second. Okay, so I'll leave that. So what if a platelet count is normal and 6 platelet concentrates are given? Happened in our hospital many years back. What if platelets are 5,000 and no platelets are given, patient is bleeding? What if a leukopenia, a bad agranulocytosis, is almost next to nothing neutrophils, is not treated? So we'll have horror Yes, to the clinician, to the lab as well. So this topic, so many of us are using analyzers. Do we know everything about the analyzers? Difficult. Do we know enough? Questionable. Are we willing to learn more and make our technologists learn more? We must do that. So, like I said this, now a lot of people think clinicians and labs are like this. We are actually at each other's throats most of the time, in most institutions. There are very few centers you will see people working together to help the patient. So what are these spurious results? The patient doesn't have this condition actually, but you report because your analyzer said so, whatever verification you did said so, and the clinician acts on this, so sometimes inappropriate management, and you're left with a problem there. So why do they occur? Lots of factors in our sample, the storage time, etc. Instrument capabilities. Some instruments will flag something, some may not. Faulty instrument calibration, that thankfully is reducing over a period of time now. The anticoagulant use, EDTA is our favorite for causing trouble as well, although we use it the most commonly. And patient or sample characteristics. Even chance will favor the prepared mind. So if we know what can happen, we can catch it. So important to increase our array of knowledge on spurious results. So what are the consequences? They may go completely undetected, misdiagnosed, you may have a delayed diagnosis, inappropriate treatment, especially with platelets. We've had so many papers, patients treated with steroids, spironectomy, bone marrow is done when it is not required at all. So questions to answer when you see an artifact. Who has this artifact? What is the clinical significance? And what action should be taken? Now, if you are a lab person or a clinician, the baseline remains treat the patient and not the test. So a 4,000 platelet count, not bleeding, no previous history, clinical diagnosis doesn't fit in, don't just start treating. Think what may be happening. So why are the analyzers? So many analyzers, so many companies, more advancements, why are they still not smart enough? Different technologies and capabilities. One is patented, one technology that picks up one artifact better than the other, one has another technology. Flagging is inconsistent, sample characteristics do affect this. Platelets, we know there can be large clumps, very large clumps, small clumps, occasional clumps, and lots of number issues. Platelets are our worst enemies, even now. Histograms may not always be abnormal, depending on the degree of abnormality. Expensive technology will limit extensive use. So this is a thing not taught in the medical school, neither in MBBS nor even in postgraduate. It's important science to develop as we are looking at advancements of analyzers. Dr. Barbara Ben, the mother of hematology for morphology for us since many years, her book has a chapter on erroneous counts and a load of information on the conditions where you can get artifactual results for hemoglobin, WBC and various parameters. And whatever we pick up in the lab, we think we picked up something. I am presenting some of that to you today, is actually the tip of the iceberg. Our lab may be missing so many artifacts still. So the job of this picture is we must spread like pollen. This information about spurious artifacts needs to go everywhere. To the budding pathologists, to the learning pathologists, teach it to the MBBS students. Because we don't even teach them properly how to interpret a CBC. That's the first report they see as they become interns. So there's a gap to be filled there. So South has a thing for advancement. I saw banana chips many years back in a conference, coming back from a conference in Kochi, saw this automated analyzer there, the machine was cutting automatically. And last year I found on the internet, this is not an HP printer, this is actually a dosa maker. Believe it or not, it's an actual dosa maker. So from Wallace Coulter, who gave us the impedance technology, to these 3 parts, the 5 parts, we have flags, we have histograms, lots of scatter plots to guide us. We have image analysis, which is digital now. How many of you have seen this movie? Okay, right, good. So this is in Hindi, but the dialogue translates into English as, it does not matter what is in front of you. It matters what you are seeing. So a CBC report may be in front of us all day. What are we seeing in that will help you to pick up the artifacts. Every analyzer has its own personality. And we must befriend our analyzer to understand it better. We must know our analyzer well. A show of hands. Which of the analyzers you think is the best? How many for 7 part? Show of hands. How many for 6 part? Show of hands. 1 or 2. 5 part? More. 3 parts? Okay, great. I do not recommend any of these analyzers. I recommend this two-part analyzer. So whatever we see every day needs to go through these two parts to make better sense of all results that we see, whatever our analyzer. So we have to sort out the spurious results for this little guy. And I'll come back to him as I end my presentation. So I'll take you through some actual case studies, except the last one, which was one of our postgraduates. In fact, 3 days before I came, he sent over this case and I've added that. So every picture that opens for the case may have a clue to what is coming up, doesn't matter really. So case 1, this is a male with an ulcer in the left tongue. Who is thought to be malignant. He was on immunosuppression for end-stage renal disease and that post-transplant for that reason. Excision biopsy was planned and a pre-op CBC showed thrombocytopenia. Lots of immunosuppression, more other drugs, possibility of a drug thing, but that's where the value of the PBF comes in. So what you see is some clumps. I think point is not coming up. You see some clumps on the sides. You see the satellitism on the neutrophils. And in some other areas, we saw platelet phagocytosis. Neutrophils engulfing platelets, very frequent. So we took the sample in citrate and heparin, as is the problem when we look at satellitism or platelet clumping, when it does not explain well. And you saw the clumps opening up, the clumps staying, but the phagocytosis completely gone, satellitism completely gone with citrate and heparin, and we got better counts. So all three automated counts were still low, although citrate was higher because the clumps persisted. But phagocytosis and satellitism disappeared. So degree of clumping was variable. We couldn't pinpoint which had more or less. So this is a follow-up. On the follow-up of this patient, there was no satellitism and platelet phagocytosis, but the clumps remained. And I followed up for 3 months, I think, after that patient didn't come back to the center. The count was adequate though. So it's important to work up a thrombocytopenia well, and there could be some of these common and even uncommon reasons. So EDTA, what is the full form? We all know that, right? I created a new one some years back. It does cause us problems at times, especially with platelet counts, this clumping issue, satellitism, and I think somebody mentioned leukoagglutination. I have one case there also. I think Dr. Rahman mentioned. So our case had spurious thrombocytopenia due to platelet clumping, satellitism, and phagocytosis, a rare combination of all three together. Case 2. This is a series of 14 patients from the clinical hematology and oncology unit when I was working at CMC. 10 were from post-BMT, so we were monitoring daily CBCs. 4 were on chemotherapy for solid cancers, counts very low, being monitored daily, counts of 100, 200, 300 TLC. And we started getting calls for each of these cases. This picked up over a larger period of time, not together, but we were getting calls. Yesterday reported 200, today it is 14,000. Yesterday was 100, today it is 3,000. BMT patients do not recover like that. So repeat samples, when we asked for repeat samples, we got expected counts. And I'll be honest, we did not pick this phenomenon till about our 5th or 6th case. Till that time, we just corrected the count and gave it. And after that, we started noting a pattern. So the hemoglobins and platelets remained okay, similar. But our initial WBC count was high, as you notice. And the figures in red are the number of times they were higher than actual. So even look at that 40. Count was 100, reported as 4,000 by the instrument. And these results are disastrous for our BMT specialist who is looking for monitoring. When is my patient going to engraft at 500, and we are giving 3,000 on the second day. So what we saw in the smear was fibrin clumps, wisps of fibrin in all these cases. And then we found out they were mostly line samples. So through these long staying cannulas, they develop a fibrin film. So when they were aspirating, probably this was coming up. All of these cases had this. That's one in higher magnification. And then I said after the 5th, 6th case, we started looking at the histograms and we noticed there was a pattern. So these are normal histograms. Look at the ascending limb, nice slope, descending limb, nice slope coming back. The patients on the left three is the initial sample and the right ones are repeat samples. So if you notice, this limb is pretty much straight compared to the other ones and the normals. So the ascending WBC limb of the histogram was very, very peculiarly straight. So what was this? We got fibrin clumps causing a spurious white cell count. WBC histograms gave a clue, and like I said, towards the end, my technologist used to say, probably we make a smear because the histogram is like that. A PBF is very helpful. You may need more than one smear at times. We had two cases where we were convinced the histogram is like that, but no fibrin clumps. We mixed the sample multiple times, made 3 smears, then found it. Fibrin doesn't come in every smear, may settle down, so you need to mix it, try more. And slow draw samples or line samples may show this artifact. A rerun will not help. A rerun will give you the same thing on the sample or from the line, so it has to be a poked sample from a vein preferably. Now, these are forget-me-not flowers, so if you think there is fibrin formed, please don't forget about the platelet count, because that must be some evidence of, if it is not a line sample, maybe a slow draw, so check the platelet count also on the repeat. I did a silly thing 2 days before I came here. I took a D, I borrowed a D from one of our faculty and I measured these angles. I extended that line and measured these angles. So all the normals had angles beyond 10, 11 to 15. All our cases, 3 of our cases and more that I have not shown here, had angles of less than 10 because of the staging. So my wish list is maybe someday, if this phenomenon is reported in more centers on 3 parts or 5 parts on the histogram, maybe some algorithm that the company people can put in, if this angle is less than 10 or 12, whatever comes up the cutoff, flag for possibly fibrin clumps. So spurious white cell count due to fibrin, in this case 3, a male with epigastric pain, portal hypertension, CBC showed low counts, pancytopenia, we thought hypersplenism straightforward, but we saw leukoagglutination. So WBC is stuck to each other that bad, that tight. I had never seen this before. We tried warming it to 37, did not open. Then the culprit always is EDTA. So you took the sample in heparin and citrate, and lo and behold, they opened up. And the count was almost double of what it was reported. Already leukopenic, now on the lower side, but double of what which was reported. So a spuriously low white cell count due to EDTA-induced leukoagglutination. Case 4. This is a lady with infective endocarditis, came with febrile illness. Sample was drawn in the emergency service. This was many, many years back. Automated platelet count is very high, or almost 12 lakhs. The smear showed less count, and what we are seeing here is bacilli. So those times we were not using the commercial tubes, we were using in-house prepared vials, antibiotic vials, washed and all, must be contaminated. But then we later found out this sample was actually sitting in the emergency for 8 hours. In the monsoons of August, September, many years back, bacterial overgrowth, platelet size matches, the machine was counting them as bacteria, or as platelets. The bacteria was being counted as. So a true thrombocyte, this was borderline 120, 130, but a true thrombocytopenia could have been left untreated if we believed only the machine. So spurious thrombocytosis, bacterial overgrowth. Now sometimes we get angry at our analyzers. So Dr. Raman said this yesterday also. I also like this when somebody tells me that the analyzer is giving wrong results on a particular sample. I usually don't know there's an answer or a diagnosis coming up. Let's see some examples. 45-year-old lady, fever and epistaxis for 4 days, spleen enlarged, CBC very suggestive, I'm thinking could be a leukemia, clinical scenario fits in, thrombocytopenia, TLC is raised. Anybody by the name of Ganesh in this hall? No, good. Okay, so the automated differential showed 70% neutrophils, that's the scatter plot. Just a magnified view, 70% neutrophils on that case. And this is Ganesh, a hypothetical resident that we had. He calls up and says, but the blood smear is showing 75% blasts. And large unstained population that ADIVA reports to be atypical lymphocytes or blast is only 0.6. Neutrophils are 70% on the machine, but the smear is showing 75% blasts. That's the comparison. So much of difference. In fact, diametrically opposite. So that is when the machine says, you don't understand me. So we need to understand the machine. I was working on ADVIA, which uses myeloperoxidase principle for staining before the laser scatters the cells. So in that, all the cells are actually put in a mixture of myeloperoxidase. Those that stain, can I take the liberty of 3-4 minutes? Okay. So the cells that stain positive go as neutrophils, those do not lymphos. If there are blasts, large unstained population, which is MPO negative. So that's where on the number 7, the pink cloud is where the neutrophils come in. That's a label. The neutrophils, metamyelocyte bands all go there. And the left is another case. To the right is our case, 75% blasts. So because the blasts were MPO positive and had granules, the machine picked up the scatter and threw them on the neutrophil side. So actually the machine was telling me you got MPO positive blasts. I got my diagnosis. That's MPO positive in that case. So this was actually an acute myeloid leukemia, MPO positive, turned out to be an AML M2 with 821 translocation. So the machine never makes a mistake. It points out to what it is getting. Case 6, fatigue, generalized weakness for 2 months, no organomegaly, pancytopenia, and Ganesh is worried again. So he's now telling me blood smear is showing 77% neutrophils, but the automated neutrophils are 43%. So if we use the same thinking process, neutrals are actually 43 point something here in our case. Peripheral smear showed dysplastic neutrophils. So there you can see pseudobar bodies, nucleus sticks, very hypogranular. So the machine did not pick up the MPO positivity, so did not throw all the neutrophils there, underreporting the neutrophils, but I got my diagnosis. So the discrepancy may be a diagnosis many times in our instruments. We need to understand that. So that was MDS, multilinear dysplasia. Hypogranular neutrophils were being undercounted by the analyzer. Case 7. 2 cases with a background of an autoimmune disease, rheumatoid arthritis, SLE with Raynaud's. CBC showed bizarre parameters in both of them. The rule of 3 is violated, so RBC count multiplied by 3 multiplied by hematocrit is not being followed. And then you have bizarre red cell indices. This can only mean one thing, there are agglutinates in your smear. So when we saw the smear, autoimmune hemolytic anemia, and look at your histograms, that was 3-part then, we worked on the 3-part at that time. Look at your RBC histograms going way beyond 200 femtoliters, irregular flutter pattern. So large particles being counted, the 3 or 4 clusters are being counted as 1, RBC count wrong, all indices wrong. You incubate the sample at 37 for about 20 minutes to 30 minutes, you will get everything back to normal, you have your diagnosis. So when the technician tells you indices are all wrong, think there's an AHA coming up, if the other samples were normal. So that was spurious RBC parameters due to autoagglutination. Coombs test positive in both of these cases. Case 8, I call this my 5 o'clock case, and it's a true story, spot story. So 5 o'clock, tired, warm, hot season, my last slide to see that day. So we had a gentleman, we had epistaxis for 2 weeks, he had smoldering myeloma, plasma cells were around 60%, but no crab features. He was on follow-up for some time. So that day his CBC was this. Now patients are clever sometimes. He had a previous report of a platelet count from outside the same day, he did not show us at that time. So our platelets were 72 and we thought elderly, maybe an element of MDS setting in, maybe the malignancy because he was not on any treatment, that could explain. Anyway, that is what his smear showed. Neutrophils, RBCs, it's a dirty slide, I agree. My first instinct was, report this off, go to sleep at home, relax. I was just plain lucky that I decided, okay, let me make one more smear. I had no clue what was coming up. So when we made the smear, we saw these on the arrows that you can see, these pale violaceous blobs, right? So this is cryoglobulins. I had not seen a case before, but we looked at some internet pictures and we thought this could be cryoglobulins. So then he said, when we started to wait, asking about the report, then he said, outside report today is 1,80,000, double of what we had reported, more than double. We then ran it on our second analyzer in the main lab, we got a different report. Same day, 3 different reports of platelets. So we separated the plasma, kept it in the fridge. Next day we got on the patient side, you can see cryoglobulins are precipitated. So cryoglobulins can interfere in various ways. It is a very unpredictable phenomena. You will not know what the next CBC will show if the patient has cryo. His bone marrow in the background when we reviewed, again had these granular debris that you can see all over. That is again cryoglobulin. So they can precipitate in various ways. I did not know this earlier, but now, in fact, last week we had done a marrow for myeloma. 2 of the slides show this pattern. And I did not take that picture. Again, we kept the plasma, less amount, but it was there. So we must be on the watch out for a background where cryas can come. Myeloma, hepatitis C are notorious for this. So spurious platelet count due to cryoglobulins. 2 quick cases, then I'll end. A boy with pallor, hepatosplenomegaly, suspected acute leukemia, almost confirmed by the count, TLC very high. We thought of a T cell ALL, but the platelets didn't go. The platelets did not go with an acute leukemia dramatic picture. We thought there should be thrombocytopenia. So blood smear showed only 30,000. Somebody else had reported and then I verified. Just finishing up now. Blast was 92. Lymphoid morphology, they could not afford more investigation, we were referred. MPO was negative, we could do, and we advised flow cytometry. Now, what you are seeing again, these blue particles, here, 2, 3 more there, are actually budded fragments of cytoplasm from the blasts. So lymphoid blasts, lymphoma cell spillover are known to be very fragile. Myeloid blasts are more sturdy that way. They shed off their cytoplasm easily. And because it was falling in the platelet size, it was counted as platelets. So you got a spuriously high platelet count. Last case. This is Dr. Vinash, our postgraduate, is now in Bihar. 25-day-old neonate. CBC was unusual. Very high hemoglobin. 37.8. Unrecordable in the second analyzer when they went to check. And this is more or less believable except for the MCH. I can believe an MCH of 104, sorry, an MCV, but MCH and MCHC were totally unbelievable because the hemoglobin obviously is not right. REW was okay. PLC and platelets were normal. And this is the sample. They collected multiple samples from twice from the same kid again, one for the biochemistry they got back again. It was white, lipemic. So I requested them for a lipid profile. Next day we got the report. High, very, very high. So this probably was a familial hyperlipidemia. We've asked for the samples of the mother, I think it's in processing, probably from there. And this high lipid will cause turbidity. How does an analyzer measure hemoglobin? Spectrophotometrically, like we do it outside. So the spectrophotometer gets a very turbid thing. Optical densities goes through the roof, you get wrong values. So spuriously raised hemoglobin due to hyperlipidemia in this case. How do we tackle spurious results? Together. The clinician and the lab need to work together. We must educate the clinician. They are busy people. They will not read this chapter alone. Okay. Stop the blame game. For the clinicians also stop the blame game. And like I said, we are doing this for this little guy. And we need to work together to sort the problems out and get a correct diagnosis on our patient. Thank you so much. I'm sorry for exceeding the time.
Sure. Thank you very much, sir.
Thank you, sir.
You have exceeded by 6 minutes, but you have taught us more points than that. So that point is well taken. It's a very narrative, beautiful talk. The first time in a talk that you have used the word teach, something has to be taught, and it has been taught this way. And we appreciate the cases shown, and very well taken. Just any questions, or we are already short of time on these cases? Yes.
Thank you for the...
Sure.
Yes, sir.
Thank you for the talk, sir. One doubt, in the case where there was spurious platelet count due to cryoglobulins, we usually expect pseudothrombocytosis. So how do you explain the thrombocytopenia, sir?
No, in that case,
Yes.
his actual count was 72 only.
Yeah, so...
He had spurious, the other counts were
so
erroneous.
your counter was right.
The counter gave 72. That was a Mindray instrument, 3-part. That gave 72. Our manual was around 70 to 90. We couldn't. The others were wrong.
Okay.
Sir.
Just a comment on your saying that in TALL you should have got a much lower count, platelet count than what the patient
No,
had.
higher. The higher count made us think of a T.
Yeah, the
Yes.
patient had higher count. That made you suspect that this could not or couldn't have been due to disease. But just to share that from experience and from the literature, it's very well known that the TALLs are usually extramedullary disease. So unless it really overwhelms the bone marrow, many cases will have reasonably good platelet count, unlike a BALL.
Right.
So just a small,
Sure.
tip that our younger generation should keep in mind, that just because platelet count is in the normal range or close to normal doesn't rule out an acute leukemia. That's the point.
True. And even, I would say, even a pH positive ALL, B-ALL can also give rise to normal counts.
And if it has developed from a CML, then actually these are the indications that this could have developed from CML.
True. Thank you, sir.
Sir, in that same case, you had said that cytoplasmic fragments were being released and they were counted as platelet. So how common is this phenomenon? Because this is not routinely observed.
I've seen 3 cases. This was my first one many years back, 2 after that.
So this is a rare phenomenon. We don't.
It'll be picked up only on the smear.
So cytoplasmic fragments, they have been counted as
I think we call
platelets.
these in tissue as lymphoglandular bodies.
Yeah.
So I thought it was akin to that. I mean, I thought this was such a great. I have already seen this.
Yes,
but
Madam, you are
thank for
absolutely right.
presenting this.
Anybody who sees cytology will know what that is. So let me conclude because we are already running short of time. As histopathologists, we generally rely on artifacts to diagnose. But here it is, this has taught us the other way. And I remember my teacher, Professor Balraman's words that the eye does not see what the mind does not know. I think this is what he has told. Thank you very much, sir. A very, very elucidative and nice lecture. Thank you.
Thank you, sir.
I have the pleasure of introducing Dr. Arvind Yeri, who is from my own alma mater, Bangalore Medical College. And sir is working in Ashwini Hospital, Vijayapura. Over to Dr. Arvind for his talk on hematological findings in neonatal septicemia.
Thank you, madam. First of all, I thank Team Mindray for giving me this opportunity to speak. And the topic which I am going to speak, already has been discussed yesterday in large proportion. Now, today I am just going to give the data collected in my hospital. So this is the hospital where I work, Dr. Bidri's Ashwini Hospital. It is a 200-bedded hospital with 150 patients for pediatric patients. Now, out of that, we have 40 beds for NICU patients. And that is my laboratory and my staff. Now, coming to the topic, neonatal sepsis. It is a clinical syndrome of bacteremia with systemic signs and symptoms of infection in the first 4 weeks of life. It is one of the leading cause of mortality and morbidity in developing countries. Now, what is the incidence? About 19 per 1,000 live births in India, and the mortality varies between 1% to 4.1%. If diagnosed early and treated aggressively with antibiotics and good support care, most of the cases can be saved. In our hospital, the patients admitted in NICU unit, 35% of the patients are neonatal sepsis patients, and remaining hyperbilirubinemia, birth asphyxia, respiratory distress syndrome, and inborn errors of metabolism. Our study included 100 babies admitted in NICU of Dr. Bidri's Ashwini Hospital during May 2023 to August 2023. We divided these 100 cases into 3 groups. The first group, sepsis with bacterial culture positive. We had 20 such cases. Then second group had all the signs and symptoms of sepsis, but culture was negative. So such cases we had 52. And the group 3 were normal babies. That is no evidence of sepsis. So they were 28 in number. Now the age and sex distribution of cases what we had. As you all know, early onset sepsis that occurs before 72 hours of life and late onset sepsis after 72 hours of life. We had 59.7% of late onset sepsis and 40.2% of early onset sepsis in our study. So this is in comparison with many other studies where early onset sepsis cases were more. And also, the age distribution in our study was, sex distribution, 68% of the patients were male babies and only 32% were female babies. Now, the methodology we followed, we collected 2 ml of venous blood in K2 EDTA anticoagulant tube, and CBC parameters were determined using Mindray BC720 analyzer, and daily 3-level QC samples were run to assure the quality of hematology analyzer. Also, blood was collected in culture bottles with aseptic precautions and sent for culture test. The bacterial culture was done using Bactec analyzer. In our study, 20 cases showed bacterial growth in blood culture. That amounts to 27.7%. So out of which Klebsiella pneumonia were grown in 10 cases, Staphylococci, different species, were grown in 7 cases, and 1 case each of Acinetobacter, Enterobacteriaceae, and Spingomonas. The hematological parameters observed were total leukocyte count, absolute neutrophil count, neutrophil percentage, immature granulocyte count and percentage, platelet count, and hemoglobin. And the cutoff values for different parameters were WBCs less than 5,000 we called leukopenia, and more than 25,000 we call leukocytosis. Then absolute neutrophil count less than 1,800 per cubic millimeter was neutropenia, and more than 5,400 per cubic millimeter was neutrophilia. And immature granulocyte count, if more than 600 per cubic millimeter, we took it increased immature granulocytes. Then platelet count less than 1.5 lakh, thrombocytopenia, and more than 4 lakhs, we called it as thrombocytosis. And hemoglobin cutoff was 13.5 grams %. Now this table shows the hematological parameters in group 1, that is culture positive cases. 20 cases we had culture positive, and out of that we found the various hematological parameters like this. That is, leukocytosis was observed in 9 cases, and leukopenia was observed in 7 cases, amounting to 45% and 35% respectively. And then normal count was observed in 4 cases. And neutrophil count and absolute neutrophil count were increased in 10 cases and decreased in 6 cases and normal in 4 cases. And also, immature granulocytes were increased in 12 cases out of 20. That is about 60% of the cases. And platelet count, we had both thrombocytosis and thrombocytopenia in 7 cases. And normal count was observed in 6 cases. And hemoglobin was surprisingly decreased in 12 cases out of 20. 60% of the patients had anemia. Now this table shows hematological parameters observed in group 2, that is culture negative cases. 52 cases were culture negative, but all the signs and symptoms of septicemia was observed in these cases. And in this group, we had leukocytosis in 34.6% of cases and leukopenia in 42.3%. And neutrophil and absolute neutrophil count were raised in 20 cases, amounting to 38.4% and decreased in 18 cases. Now platelet count, again in this group, we had thrombocytosis in 17 cases and thrombocytopenia in 20 cases. And immature granulocyte count was increased in 30 cases out of 52 and normal in 22 cases. And hemoglobin was again decreased in 12 cases and it was normal in 40 cases. Now in the last group, that is the normal babies who had no signs and symptoms of sepsis. And such cases also we found leukocytosis in 9 patients, leukopenia in only 1 patient, and 18 patients out of 28 are showing normal count. And similarly, neutrophil and absolute neutrophil count were normal in 19 cases out of 28. And immature granulocyte count was more in 5 patients and normal in 23 babies. Platelet count again, we had all 3, parathrombocytosis in 4, thrombocytopenia in 2 cases, and normal in 22 patients. Now, based on the values, we can also have hematological scoring system of Rodwell et al., which is a simple, rapid and cost-effective tool as a screening test for the early diagnosis of sepsis. The criteria for scoring is leukocyte count less than 5,000, 1, and more than 25,000 at birth, again 1 score, and more than 30,000 at 12 to 24 hours after birth was 1, and day 2 onwards, again if the count is more than 21,000, 1 score. And absolute neutrophil count, if it was increased or decreased, 1 score was given, and immature granulocytes, if increased, again score 1, and other parameters, which again yesterday was dealt in detail, that is the ratio of immature cells with polymorphonuclear cells, if it is increased, again 1 score, and ratio of immature to mature polymorphonuclear cells, if it is more than 0.3, score 1, and platelet count, if it was decreased less than 1.5 lakhs, 1 score was given. And interpretation of the scoring system, if the score is less than 2, sepsis is unlikely. If the score between 3 and 4, sepsis is possible, and if the score is more than 5, sepsis is very likely. In our study, group 1, that is culture positive cases, out of 20, 16 scored more than 5. That is nearly 80% of the patients. And in the group 2, that is 52 cases where 34, out of 52, 34 scored more than 5. Now coming to the discussion part. So in our study, 68% of the male babies were affected compared to 32% of the female babies, and late onset sepsis was 59.7% compared to early onset sepsis, that is 40.2%. And these two, again, compared to many other studies, were differing. In many other studies, it was early onset sepsis, which is more, and also female babies are affected more in many other studies which I referred. And in our study, 27.7% of the cases showed culture positive. Though many cases are suspected of sepsis, culture, we don't get culture positivity in all the cases. So we had only 27.7% of the cases showing culture positivity. And now group 1 in our study, 80% of the cases showed either leukopenia or leukocytosis. That is for 35% leukopenia and 45% leukocytosis. And then again, absolute neutrophil count was increased in 50% of the cases and decreased in 30% of the cases. And immature granulocyte count was increased in 60% of the cases. Now again, group 2, that is, as I said, culture negative, but all the signs and symptoms of sepsis. In these cases, again, leukopenia was more, that is 42.3% compared to leukocytosis, and absolute neutrophil count was increased in 38.4%. And immature granulocyte count was also increased in 57.6%, and thrombocytopenia was showed in 38.4% of cases. So this is the graphical representation of neonatal sepsis cases in our study. Now, immature granulocyte was raised in 58.3% of cases. Then neutrophilia was observed in 41.6%, and leukopenia was observed in 40.2%, and leukocytosis in 37.5%, thrombocytopenia in 37.5%, and anemia was observed in 33.3% of cases. So this graph, it represents the both, that is proven sepsis, 20 cases, and also clinically strongly suspected cases with culture negative, that 52 plus 20. Out of 72 cases, this graph has been taken. Now, total leukocyte count, absolute neutrophil count, and immature granulocytes and platelet count are very good sensitive tests for neonatal sepsis, and leukopenia has better specificity than leukocytosis, and immature granulocyte count is accepted as a useful indicator for neonatal sepsis. Immature granulocytes in peripheral blood reflect an active bone marrow response to bacterial infection. Now, the advances in technology have enabled automated hematology analyzers to identify and count immature granulocytes, resulting in improved quality and cost. I am using Mindray BC 720, which is, so far I am very happy with the results what I am getting in this counter. So neonatal sepsis results in high rates of morbidity and mortality. Early and precise detection of sepsis will improve the clinical outcome and reduce the antibiotic usage. Though blood culture test remains the gold standard for neonatal sepsis diagnosis, hematology parameters certainly help for the early diagnosis and treatment of sepsis. Now, finally, simple and rapid laboratory test like CBC in a good hematology analyzer plays an important role in the early diagnosis of neonatal sepsis. Thank you.
So thank you, Dr. Arvind. I think you have very well highlighted the role of CBC in the context of neonatal sepsis.
Yes,
and I think your study has been in a very organized manner. You've been able to categorize them and highlight the usefulness of these basic parameters. I think I may have missed this point. In the scoring system that you described, did thrombocytopenia and thrombocytosis also get some scores?
Yeah, thrombocytopenia was included.
Okay, not thrombocytosis.
Not thrombocytosis.
Okay, because sometimes thrombocytosis is also an
is
indicator.
also there, but in that Rodwell system, only thrombocytopenia is accepted.
Okay. Thank you, sir. Any questions from the group? Yes, sir. Yes, please.
Okay. My question is, if the cases with leukopenia is better the immature grants in percentage than in absolute number?
Yeah, absolute neutrophil count was taken as a good parameter for this.
Yeah.
I'm not able to.
I understand your question.
Yeah.
The shift to the left in a leukopenic patient.
Okay.
So what Dr. Ramon wants to know,
Yeah.
did you see that in leukopenic patients?
No, in fact, we have not.
Immature
Yes, now I understood that. Now, in fact, all these data collected was only on the analyzer. We have not done any smear preparation to see the shift to the left. So I just cannot comment on that, because all the data, it was only on the analyzer based data. It was not done by smear preparation, and I have not studied that actually shift to the left in this.
Okay, thank you.
Suppose you get a neonate, one, and you have to give an opinion.
Yeah.
Whether that baby is septic or not.
Yeah.
See, that is what is prime importance to the neonatologist.
Correct.
The data over so many percentage, everything is good.
Yeah.
But in an individual baby, what would be your criteria to say this baby is septic and not septic?
Yes.
According
Now,
to your
it is clinician who has to decide the signs and symptoms of the baby. And for me, the test CBC is the best thing. And if we combine it with C-reactive protein and if possible, micro ESR also, if we take these 2, 3 together, we can definitely predict that this baby is septic. Because, though the culture test is the best, but we don't get the report, immediately. It takes 3 days, 5 days like that. So to give the early diagnosis, I feel clinician has to see the CBC report along with CRP test, and he has to correlate with clinical signs and symptoms for the best diagnosis.
Yeah, I agree, but these two parameters, CRP
Yeah.
and ESR,
You see, yeah.
we know if a baby is born after a difficult labor, CRP rises. And those are the babies that neonatologists are worried about. They would like to know whether that baby who's gone through difficult labor is septic or not. And blood culture will take 48 hours.
Yes.
So yes, immature granulocytes. So we have been following, as I've always discussed, the immature, band cell to neutrophil ratio.
Correct.
And even ESR does not help in neonatology, basically. So we did a correlation of ESR, CRP, IL-6 and band cells and band cell neutrophil ratio. With eosinopenia, I every time give an importance to eosinophils. I think you can, on an individual baby, on a slide, whether there is a clinical evidence or not, you can predict sepsis.
Yes. Thank you.
So did you try and do procalcitonin at least in the group 2 who were blood culture negative?
Not to all the babies. Few babies we did procalcitonin because, again, the cost matters in a small place. Vijaypur is a small city where people don't spend much. So because of that, many times clinicians, they don't ask for procalcitonin. But few cases they have asked and we have reported. But now here I am just trying to present only the hematological findings.
Now, we took up one study where we looked at the band neutrophil ratio, as ma'am said. That was one thing which made a significant impact. CRP level, procalcitonin, and neutrophil lymphocyte ratio also.
Okay.
We found that was also one significant parameter which we just recently actually published that data.
Now, for the band cell neutrophil ratio, again, we have to prepare the smear and see. That is the thing. But now here I am trying to correlate the findings of hematology analyzer with clinical features. That's
One more question. You said that there were more male babies more than the female
Yeah.
babies. So did the ratio was initially equal number of babies was seen to see this change of pattern, or
no, this is the
to
first.
start with, if you had more male babies, maybe
No, that is not the thing. Overall, for the period of last 3 months we studied. In the 3 months, male babies were more compared to female babies. I don't know in that area, more male babies are being born. Maybe
that is the reason that you may have got that
Larger numbers. Yeah. Anyway, I think this has always been a topic of interest, never-ending questions and never-ending learning points. Thank you so much for presenting this paper, and we have learned a lot from all the inputs. Thank you very much.
Moving ahead for the day, may I call on stage Dr. Vinanti Golvilkar, and may I request Dr. Ashwini Sengupta to chair the session, please.
Good afternoon. I think my pleasure to introduce Dr. Vinanti Golvilkar. She has completed her MBBS and MD from BJ Medical College and Sassoon's Hospital, Pune, one of my favorite places to go, and excelled in academics with first rank in MD pathology, and has an opportunity to work at Tata Memorial Hospital, Mumbai, and is doing many new essays and introducing new tests and technologies since she's joined her father's laboratory since 2014 with her interest in hematopathology. So let's hear Dr. Vinanti Golvilkar.
Thank you, ma'am, for the kind introduction. And at the outset, I would like to thank Team Mindray, particularly Shama, for giving me this opportunity. Beginning my talk with a little information about the organization, AG Diagnostics. We are a state-of-art clinical diagnostics laboratory spread over 16,000 square feet in the heart of the city of Pune. We have 60 plus collection centers across Pune and PCMC region, with 7 hospital labs, and our strength is our experienced team of technologists and 15 experienced pathologists and microbiologists. I have captured this data for platelet count over the last 6 months in our laboratory so that you will understand the profile of our patients. If you can see, nearly 88 to 90% of our patients fall into the normal range, and moderate to severe thrombocytopenia or severe thrombocytosis accounts for less than 2% of the cases. These are the platforms we currently have at our centers. And if you have a look at them, you would realize that we have always worked with platelets by impedance method, the platelet eye. And as many of you would agree with me, when you work with an analyzer for a long time, you tend to develop an attachment and comfort level with it. So you tend to accept it with all its limitations. It's important to know the limitations of the method you're using and work your way or report your results taking that into consideration. And accordingly, we have a stringent protocol for release of automated platelet count at AG Diagnostics. So we review any counts less than 1.5 lakhs or more than 5.5 lakhs of per cubic millimeter of platelets, in which case we review the CBC histogram and correlate with the rest of the CBC parameters, associated tests requested like dengue, NS1 or IgM, rapid malaria and fever profile. We go through the delta check available in our lab through our software. If it is our own follow-up patient, we do trend analysis of the count and go through the previous report. A peripheral blood smear review is done by a pathologist where we correlate the platelet count, look for large platelets, giant platelets, platelet clumps, satellitism, possible pseudo thrombocytopenia, presence of microcytic RBCs or RBC fragments, giving possible interferences and associated findings, reactive lymphocytes, malarial parasite. If it is a new patient or there is a significant change in the delta values in our follow-ups, cases of moderate to marked thrombocytopenia, and cases where we feel there is a need to change the count given by the analyzer, it is rechecked by a second pathologist, and then we release the report. So while putting this up, I came across an article which gives a methodical approach to interpreting the platelet parameters of the complete blood count. And what this article states is interpretation of laboratory results by laboratorians incorporates two levels of analysis. One is the validity of the results to answer the question, can these results be reported? And the other is the clinical significance, whether subsequent actions like reflex testing, critical values procedures, or notifications to other departments are warranted. Now, the literature frequently contains algorithms that are focused on the diagnostic aspects of test interpretation, but this article has focused on the validation aspect, which it is calling as heuristic, that is, you learn for yourself. And I had described my heuristic or our heuristic at AG Diagnostics in the previous slide. This article mentions the steps for interpreting platelet portion of the complete blood count, where it takes into account the total platelet count, MPV, PDW, the platelet distribution histogram, IPF, then correlate the numerical parameters with the platelet morphology, and then correlate platelet results with RBC and WBC parameters and conduct clinical assessment of the patient's values. So now moving on to the new kid on the block, which we have installed in one of our hospital laboratories 6 months back. Nice compact tabletop model. The highlights are the 3D SF cube technology and platelet etch and IPF. It also gives ESR with CBC, but that would not be the focus of my talk. So we ran a sample, 39 years male, who had come for a routine checkup on this BC700. And so I was looking for a platelet count here, and what have I got? So on this, in the WBC diff mode, which is called CD mode on this platform, we got all these results. So a platelet count, which is the platelet H, because that's what we have selected for our platelet reporting, of 207,000, a platelet I by impedance of 206,000. We also got PLCC and IPF in the diff channel itself. Going through the principles, it applies sheath flow impedance method for RBCs and platelets, laser scatter, and the SF cube fluorescent cell analysis technology for the WBC differential. This involves 3D analysis using information from forward laser scatter, side laser scatter, and fluorescent signals. Platelets are measured by the sheath flow impedance method, which counts platelets by sorting and detecting the pulses falling in the platelet channel per cell size. However, we all know that impedance method is vulnerable to interferences. We can get a false high value in the presence of microcytic RBCs or RBC fragments. We can get a false low value in the presence of large platelets. Possible solution till now has been optical platelets, but it has to be rerun in the reticulocyte channel involving extra reagent consumption, a rerun and higher cost. So now we have another solution, this platelet H or platelet count hybrid on the BC700. Here platelets are counted in the diff channel, which adopts the fluorescent staining technology. RBCs are lyse, so the count of platelets in the relatively large sizes in the diff channel will not be affected by the erythrocytes. Now, by combining the large size platelet count result in the diff channel and the small size platelet count result in the impedance channel, the analyzer arrives at the platelet H, which is a reportable parameter on this instrument and is said to have the same clinical performance as platelet O. Results have been found to be stable up to 24 hours at room temperature and 48 hours if maintained in appropriate cold chain during transport. So these are the various platelet parameters available on this instrument. Platelet count I've already discussed, mean platelet volume, which is calculated based on the platelet histogram, platelet distribution width derived from the platelet histogram as 10 geometric SD, platelet grid. But what we also have is the platelet large cell ratio, immature platelet fraction, and the platelet count hybrid. So platelet large cell ratio is derived from the platelet histogram. It represents the ratio of the number of platelets with a size over 12 femtoliters to the total platelet number. So the S2 region in this figure. This is taken from the diff channel combined with the small platelets on the impedance channel, and the platelet H is arrived at. So platelet I, platelet H, and platelet O, all of them are reportable parameters. Only platelet will be shown in the reportable page. You can look for the other counts in the other parameter page. The CBC mode reports platelet I, CD mode reports platelet H, CDR, that is the retic channel mode, will report platelet O. So what are the advantages of platelet H? We can say an optical equivalent of platelets in every CD test. It avoids interferences of fragmented RBCs, microcytic RBCs, or large platelets. There is no need of a red channel or red reagents and no additional reagent consumption in the CD mode. However, it does not solve platelet clumping problem, which is possible only with platelet O, where it can deaggregate the platelet clumps. I'll take you through a few cases. This was a 66 years old male, known case of prostate cancer on chemotherapy. This is the run on our DXH 900, which showed a platelet count of 40,000. There was no review flag by impedance method. We ran it on the BC 700. Again, we got a platelet count, platelet H 40,000, platelet I 41,000, so correlating, and the IPF was 8.5%. Now, it is important to note that the normal range for IPF on this analyzer has been defined up to 10%. So this falls within the normal range. Just showing a snapshot of the delta review we get from AG Diagnostics lab software, and we monitor platelet counts likewise. So this is the same patient, and the platelet count has remained in a similar range on further follow-ups. The next is a case, 39 years of male, dengue NS1 positive on follow-up for platelet count. We saw reactive lymphocytes on peripheral blood smear and large platelets. So this was our DXH run, showed a platelet count of 20,000. However, there was a R review flag, which alerted us to a possible presence of large platelets. On the BC 700, the platelet H was slightly higher, 27,000, platelet I 22,000, and an IPF of 22.9%. This was a 76 years male patient, known case of immune thrombocytopenic purpura. So platelet H and I gave similar values. IPF was high, 21.9%. We got this IPF confirmed on an optical platform, wherein the IPF value came to be 19.8%. So it correlated. So till now, I took you through case of cancer chemotherapy follow-up, which showed a normal IPF. A case of dengue, NS1 positive follow-up platelets showing a high IPF, and ITP showing high IPF. But now I'm going to get an interesting perspective with this particular case, which was admitted in this hospital, where we have this instrument with urosepsis, 72 years male. So the platelet H here was 70, platelet I was lower, 53, showing possible large platelets. IPF was higher normal, 10.6%, MPV also high normal. The patient, being that of sepsis, had marked polymorphonuclear leukocytosis. This was day 1. On day 2, platelets fell a little further, but IPF went up, 15.3%. WBC count came down a little with antibiotic therapy initiation. Day 3, platelet count went a little down further, but IPF went up markedly, 32.9%. WBC total count has come within the normal range. So this is what we have got, the data of the same patient over 3 days. So WBC count has come down with antibiotic therapy initiation. Platelet H has come down slightly. Platelet I parallelly is lower than platelet H. IPF has gone on increasing. Basically, there is so much data. So here I would take this saying, now we are going to get a lot of data in the routine diff channel run, and we could possibly have many associations which we do not know at this point in time, and our eyes don't see what the mind doesn't know. And in this era of predictive healthcare, artificial intelligence, data analytics, I think we have a lot of scope with all this data coming with every analysis. So a lot of studies are now coming with respect to platelets. So till now, we were looking at IPF as a good prognostic marker in thrombocytopenic patients. But IPF and MPV are now considered as adverse cardiovascular risk markers akin to CRP in HSCRP, and studies are going on, and we can have lot of such data coming up in future. So we have been reporting IPF on this platform over the last 3 months. To summarize, platelet H and IPF on BC 700 has shown good correlation with morphology on peripheral smear and clinical findings. Several new parameters available with every run on the CD module. So it's like a playground for data analytics to give new insights into possible associations and clinical applications. And still there is a lot of scope for learning in near future. I would like to thank my team and thank you all for your patient listening.
Thank you, Dr. Govilkar. I think that was very elucidative, and thank you for new parameters, that is platelet H and IPF has been there for quite some time now, but yes, more work can be done in other, in situations like cardiovascular. So this is open for discussion. Yes, ma'am.
Very good compilation of data, Vinanthi.
Thank you.
Very nice to see that. One little query is there. Normally we say that if IPF increases, then within 24 to 48 hours, you would expect an increase in the platelet counts. Now for 3 days, the IPF has been increasing and the platelets have been falling. Any thoughts on that? Have you seen the 5th day report, whether the counts came up or not?
Ma'am, the patient was discharged, so I got only 3 days.
Yeah, because...
But that's what I have mentioned. It's a scope. We have never analyzed it all together in a complete way. So it could bring us new insights, is what I thought.
Yeah, we would.
Ma'am, that was a very interesting question. Actually, we have seen cases where the IPF has gone up and we expected the platelet count to recover within 2 to 3 days or maximally 4. So we went back and we saw the data and we realized in some of the cases, the CBC showed a macrocytic indices. We got the serum B12 and folate done for those patients and it came out to be low. We gave them B12 and the platelets recovered. So when the platelets actually fall, then recovery is tough if you have a deficiency of B12 or folate. So one of the experiences.
May I request Dr. Rajesh Patale, the next speaker, to be on the stage, please? And may I request Dr. Rama Manchanda to chair the session?
Good afternoon, and gives me a lot of pleasure to present our colleague from Pune, Dr. Rajesh, who has received his training in hemostasis, molecular biology, and quality management. He is he's an assessor also, being a good hematopathologist, and has been trained by lot of workshops in coagulation and lot of interest in bone marrow, bleeding disorders and electrophoresis, wide spectrum of working culture. But Rajesh, we look forward to listening to you on mean platelet volume. Lot of discussion has already happened, advantages and limitations. Thank you, Rajesh.
Thank you very much, ma'am, for that kind introduction. At the outset, let me thank Mindray team for inviting me and making me this part of this academic feast, going over for last 1.5 days. So, I'll be speaking on mean platelet volume. So, specifically, I chose this topic since most of the people or most of the labs are still using 3-part analyzers, and the available parameter for platelets apart from the platelet count is the mean platelet volume. And even for those who are using 5-part or 7-part analyzers, and because of my own favorism towards the histograms, I thought MPV is a better choice for a discussion. Of course, a lot has been discussed in the previous talk from Dr. Vinanthi about the IPF, the platelet H or the platelet I also. So before I actually go towards the mean platelet volume, let me have some disclaimers that the automated platelet count, this is the first slide. So ISLH has given the peripheral smear review criteria for a platelet count below 100,000. And if there is a significant delta check which is failed, and if there are flags which include platelet clumps. So these flags are most of the times available on even the 3-part analyzers and this or 5-part analyzers. Apart from that, the clinical decision-making values, of course, less than 20,000 platelet count is a must to have a smear review. But 50,000 to 100,000 also is an area which needs a significant consideration for smear review, and the reasons we have seen in the previous presentations also. And the ICSH critical allied interval has been defined as less than 50,000 as the parameter. Now, before I go to the MPV, again, a simple thing or repetition. The platelet, the techniques for the counting of platelets by the automated analyzers is the first and foremost is the impedance method, wherein the pulse is generated. The second is the optical oblique the fluorescence method. There is difference between the dyes which are being used. In optical method, the polymethylene dye is used, and in the fluorescent method, oxazine dye is used, and the discriminator is set in such a manner that the platelets are counted in the fluorescent channel. And the third method is the immunological platelet method, which is the most accurate and the recommended or the reference method for the establishment of the platelet count. Now, we'll straight away go to the limitations of the impedance and the optical method. For impedance method, it can give false low counts because of the in samples which do have large platelets which are not counted by the machine. And if there are significant interferences, the interferences will be like giant platelets in ITP patients, platelet clumps as we have already seen in the previous talks, and in some of the patients of having RBC fragments or microcytes. In optical methods, it is assumed that the falsely high counts have been established since the discriminator on the fluorescent channel is set on the lower mode, so the small platelets are counted and you can get falsely high count. And of course, the drawback of immunological method is the high cost. So with that, I'll come to the platelet, the schematic diagram, how the platelets are counted. So in most of the times, the platelets are counted between 2 to 20 femtoliters channel. Most of the analyzers are having the discriminator for the platelets as between 2 to 20 femtoliters. Any particle which comes in that area has been counted as platelet, and a histogram is generated, which has to be a double histogram with a, it should start from 2, it should end at 20, and it is slightly having a shift to left. That is particularly for the platelets. And with that, if a vertical is drawn from the peak of this histogram, then it is accounting for the mean platelet volume. So this is the basic principle for the impedance, and this MPV which is generated is most of the times useful in different conditions. And in thrombocytopenic patients, if you get a low MPV, then you are most of the times dealing with a hypoproliferative marrow like an aplastic anemia. If the MPV is high, then you are dealing with an hyperproliferative marrow conditions, or ITP patients, DIC, or some infiltrative disorders can be thought of based on the MPV values, but this has to be correlated with the other cell count parameters as well. So MPV in a patient or in a case of thrombocytosis, if it is low, then most of the times it is assumed to be a reactive thrombocytosis, but you can get cases wherein the patient has persistent thrombocytosis with a normal or low MPV, which can turn out to be a case of chronic myeloproliferative neoplasm. But invariably, if the MPV is high in a case of thrombocytosis, then you may be dealing with a chronic myeloproliferative neoplasm. Now, we did a study during the last September for the platelet count. So a total of 7,340 cases were there, wherein thrombocytopenic patients were counted. Almost 10% were within the 100 to 150,000 category. So 8% in 50 to 1,000, and below 20,000 were almost 300 cases. So we evaluated this less than 20,000 platelet count samples, and of course all these smears were reviewed, but I will just go through the smear review of this category of less than 20,000. So out of those, almost 190 cases were non-infectious, since we have an active unit of hematology going on plus the oncology. The majority of patients belong to the non-infectious category, and the infectious patients were 96. Now out of these, when we reviewed the smear, only 7 of the infectious category showed discrepancy between the machine count and the manual count. And only 21 cases of non-infectious category showed discrepancy. Rest of the non-discrepant samples were quite high, wherein the machine count and the manual count were very well matching. And when we check the samples from infectious category patient for subsequent samples and the platelet counts, when we saw the platelet counts were increasing, at the same time the MPV also was increasing in the follow-up samples. But as ma'am, we were discussing right now about the IPF, the last count which showed the count was increasing, but the MPV dropped. So that may be an area wherein the IPF goes down once the platelet recovery starts. So till this recovering phases, even this, the count recovery was not significantly high. From 30,000, it has gone to 50,000 only. But the MPV was significantly high, and the last count showed a slight drop in the or maintenance of the mean platelet volume. Okay, so with this, one disclaimer will always be there that platelet count and MPV should be read hand in hand. Only platelet count or only mean platelet volume, it should not be interpreted on its own. Because, and it is always mentioned that these go together as an inverse non-linear correlation. Okay, as the count goes up, the MPV may go down unless and until there is a specific pathology related to the condition. Now, this is the histogram. If you get, now this is the right side histogram is the ideal histogram. Now, in this patient, the sample, the machine will not be able to analyze the mean platelet volume where it should be doing. And even if the machine is giving you the mean platelet volume, it will be a non-representative MPV value. Okay, and that will be because of these kind of large platelets that you see. So you have to have a good look at the platelet histogram and then only go ahead with the interpretation of the smear review as well and this machine counts as well. So the advantages of MPV are, since it's a derived parameter, it is derived from the histogram, no additional cost comes, so it is relatively cheaper and it is available even in 3-part analyzer. So any lab can just evaluate the mean platelet volumes based on the information available in the histogram. And it correlates very well with the platelet activity, that is in cases of infections, patients on chemotherapy or stem cell transplant patients or inflammatory or prothrombotic conditions. Now, you can see raised MPV in following conditions and it does have a significant impact. So, in cases of cardiovascular conditions, it carries, the high MPV carries a risk of acute cardiac events and increased risk of death in cases of acute myocardial infarction. Cerebral stroke, same scenario, and it can be used for monitoring of the recombinant human erythropoietin levels in patients of chronic renal failure. But it carries, a high MPV carries a risk of clotting. So what are the limitations? Now, in majority of the myelodysplastic conditions or in a few of the inherited platelet function disorders like the Bernard-Sollier syndrome or gray platelet syndrome, you do have large platelets. So thereby, you will get a high MPV. But most of the times, these are non-functional platelets. In the recovering marrows or in patients of viral fevers or infectious etiology, the recovering platelets are functional platelets. These are not the functional platelets. These are the hypogranular platelets, but you will get a raised MPV, which is of no use actually. So you cannot rely on that raised MPV value in conditions like that. That's why now this large platelets of ITP versus a large platelet or a giant hypogranular platelet in a myelodysplastic syndrome. The machine based on MPV or based on histogram will not be able to differentiate what is the morphology of this hypogranular platelet. So again, this has to be correlated with other CBC parameters, but you have to keep a caution in your mind that it is not going to help you in these conditions. Now, can an optical or fluorescence method of platelet count is helpful in these conditions to analyze a giant hypogranular platelets. So now most of the times the large platelets are lying in the black ground where we see the giant platelets. So hypogranular platelets, can those have low fluorescence and can those lie in the red area, which we will have to evaluate. And MPV, there are significant pre-analytical influences. Of course, venipuncture with or without stasis. If there is a stasis, then there can be a chance of getting a platelet aggregates and which can impact the MPV as well. Underfill, overfill, that is the EDTA proportion which is available for the sample. Inadequate mixing again can have platelet clumps. And it is mentioned that at room temperature or cooler than cooler temperature, you can get artificially raised MPV in a sample if it is not stored properly. Analytical influences, as yes ma'am, we were discussing about the harmonization of the equipments. Now, majority of the analyzer manufacturers do have the 2 to 20 femtoliters of the discriminator for the platelet count. But there are some analyzers with 30 femtoliter cutoffs. So there will definitely be some variation when you get values between these two analyzers. So the range of detection or the range of discriminator has to be uniform, or there has to be harmonization between the manufacturers. Plus, between the methods also, there can be different variations. And of course, the impact of RBC fragments and giant platelets, how it is going to address. Yes. And in patients with the constitutional macrothrombocytopenia patient, as was discussed in the morning, some analyzers do give 30,000 or 40,000, but actual machine count, actual manual count is somewhere around 80 or 90,000. And some of the analyzers do give the value of more than 70, 80,000. So these analytical influences, we have to come up and do some harmonization studies or the activities so that the machine, the inter-instrument variation goes down. And this lack of standardization is there available because there is no calibration point available for the mean platelet volume. There is no standard available or the calibrator available for that. And there are no validated cutoffs for the mean platelet volumes. And it is dependent upon the method also. So there is no uniformity between the cutoffs. So this also an issue needs to be addressed. Similarly, there are no internal IQC samples or aqueous material available. And it has been shown that equipment to equipment variability is around 25%. So can we have some role of artificial intelligence which addresses the morphological details of the giant platelets or the giant hypogranular platelets? And it can be possible. It is possible because AI does use the image library which is available in the machine. Plus, if we have to use middleware, then are we going to deal only with the platelet count, or can we use mean platelet volume as a parameter for the algorithm to be developed? And for delta checks to be applied for MPV, there are no accepted values between the delta check values, whether to be accepted on the value-based MPV or a percent difference. And that can be used for automated selection of verification. So with that, I end my talk and I'm open for the discussion. Thank you very much.
May I call Dr. Mahesh Karigowda? And may I request Dr. Rama Manchanda madam to chair the session again, please?
We are now ready to listen to IPF, again, the problems, the small cells, and Dr. Mahesh Karigowda. Is that right?
Yes, ma'am.
Okay, thank you. He's a consultant at the Diagnostic Laboratories and Professor of Pathology, BLD University, formerly, and presently is the consultant pathologist at his own lab. That is your Haridaugar Diagnostic Laboratory.
Yes, ma'am.
A lot of publication, lot of work he has been doing. His main interest is in histopathology, hematology, cytology. Diverse interests, but I'm sure he is focusing more on the dots that he's going to talk about, IPF and bone marrow in hematological disorders. Welcome, Dr. Mahesh.
Thank you, madam. The IPF debate happened just a few minutes back. It's early platelets what we concluded, but I'm going to use IPF because I can't change just 1 minute. And this Vijaypur is a very small place. Dr. Eri is, both of us are in Bijapur. It's a very around 5-6 population, 5 to 6 lakhs population. And we struggle to give the more accurate, reliable, and we discuss with the clinicians. And in the last few years, a lot of new parameters have come in. So we started using that one. Regarding this, we use this IPF in a day-to-day practice. Coming to the immature platelet fraction, this we know that they have been introduced in last 1 or 2 decades ago, and IPF represents the subsets of platelets. It's the early platelets which has got a high RNA contents, and they represent the most recently released from the bone marrow into the peripheral blood. They are analogs to the reticulocytes of RBCs, and it can only be measured by the cell counters. The why this study, I have taken it because there are certain reasons are there. There was a need of IPF in 2015 and 16 because of dengue outbreak, and many cases were needed IPF, and we procured the 5-part differential with the retic mode. And it has benefited a lot of patients during that time. And we used to do reticulocytes only on request, and you know that outbreaks was seasonal. And soon we realized that this retic dye has got a short expiry and on-board stability is very low. Once the expiry date on, the machines, we have to replace. We are forced to replace that new reagents. Otherwise, only CBC diff used to get blocked. Then going back to the, in 2000 plus, where I began my career there, we used to do peripheral smear because we got some of the pathologist lab there, and many of the small cell counters they used to run, and they send the peripheral smear to us. Then soon we realized that the count on manual, when it comes to low, normal or something like it was very difficult. Then we started using all the peripheral smears with 3 parts. That was our mandatory in my lab. And it gives a confidence for me as a pathologist, and clinicians and patients are also happy. And we used to do reticulocytes manually. And once we bought this 5-part, so instead of using the reagent, we just marginally raised the charge fees of peripheral smear by around 20, 30 or 50 rupees. And we started running the peripheral smears with this counts with the retic and IPF mode. And at the same time we are consuming the reagents, we also got some more information in our day-to-day practice. And in certain cases, it really helped us to arrive at the diagnosis. And whenever the bone marrow comes, we do a peripheral smear with CBC and retic. All data will be there when the slides are ready. With this, I'll just give an example. In the month of March, just last month, we had a case, 4 years, female child, anemia and mild splenomegaly. Clinicians were of doubt having this thalassemia or something else. They sent a peripheral smear, HB electrophoresis, set of investigations. And peripheral showed the normocytic with normochromia and few spirocytes. And we ran electrophoresis was near normal, except that HbF was mildly raised. Then DCT was negative, ANA was negative, osmotic fragility was mildly elevated, HB electrophoresis was normal, and this, our CBC retic count gave 13.9%. Then we did a manual stain, nice hinge bodies, and we just reviewed our slide, bite cells were there. So this is a case of G6PD. Now coming to the CBC, IPF and the bone marrow pathology. In the subconscious, I'm sure that it was helping me a lot, but I didn't have a data. So with this, Mindray called me, why can't you do some study and do it? Then I took a data of this one. I took a bone marrow data from Jan 21 to August 23 for 32 months. And we included that all the causes of thrombocytopenia, let it be clubbed together. So it can be a reduced thrombopoiesis or increased platelet destruction or consumptions, or it can be abnormal distribution like sequestration, what it happens in fibrosis or something else. And we included all the cases where bone marrow data is available, platelet parameters and IPFs were available. So in this 32 months, we had a data of 562 bone marrow aspirate and 112 biopsy. And this is with a gender distribution is almost equal, and age distribution started with the 4 months to 85 years data was there. And we case filtered based on the causative factor for thrombocytopenia. So we divided into these 5 categories: ITP, megaloblastic anemia, hypocellular aplastic anemia, acute leukemia, or myeloproliferative, particularly the MDS and myelofibrosis. So in total, around 200 cases we had. Then we started taking about the each data. ITP comprised around 65 cases, and I don't want to go into that age and gender distribution. And then this is ITP having all megakaryocytes normal to hypercellular, and many are having a hypolobulated or a small platelets, megakaryocytes, what you call it, the exhaustive megakaryocytes. Then megaloblastic, we had 48 cases. This is a pure megaloblastic, not a mixed erythroid, a pure megaloblastic. This is a very nice megaloblast in the bone marrow aspirate. Then we had around 11 cases of aplastic anemia or a hypocellular marrow. One interesting point that this hypocellular marrow were common in the early period of decades in life and in the later period. One example in June 2021, just after the COVID outbreak or during the COVID outbreak, that 50 years male patient, he has recovered from the COVID pneumonia with the 18 score, and after 2 months, he was readmitted with the breathlessness. No, during COVID, many were thinking about COVID. And CBC had showed that 2,900 cell count, HB is around 8% and platelets around 80,000. Then we received a peripheral smear, and no peripheral smear, we ran with all CBC retic. Then it showed NC with pancytopenia, and IPF was around 1.6. Then somehow that I should convey this to the clinician. Then we conveyed that platelets are likely to deteriorate. Then we did a day 2 repeat platelets 0.62 lakhs and IPF dipped to 1.5, and we advised for the bone marrow. And it did show hypercellular marrow with few megakaryocytes were there, and unfortunately lot of histiocytes were there with a lymphocytic phagocytosis, then erythroid phagocytosis, and this is a case of HLS syndrome. Probably it's a COVID induced, so we don't know exactly, and patient succumbed within a week. And it has been proved with ferritin, triglycerides, LDH, and fibrinogens. Acute leukemia, we had around 56 cases, and these are various blasts in the smears. And myelodysplastic syndrome and myelofibrosis, we had around 20 cases. Now, once we started doing the biopsies, a lot of cases has been picked up. And this is again an interesting case. Is a 65 years male, is an alcoholic and had a cirrhosis of mild grade with splenomegaly. He admitted with the pain abdomen. Ultrasound shows there is a splenic vein thrombosis. And count showed 4,100 cells, 10.5 HB, and platelet is 1.7 lakhs. And as you know that whenever we receive peripheral smear, we do all these things, and IPF was 12.1. Somehow that is not matching, and we discussed with the clinician whether steroids has been given or something like that, and he conveyed that his record shows splenomegaly from 5 to 6 years, and it is disproportionate large with the grade of a cirrhosis. And they also wanted to find the cause for this. So we advised for the bone marrow here, and unfortunately he landed with the emergency splenectomy was done on the day 4. And this is bone marrow aspect shows a lot of megakaryocytes with the dysplastic features, and biopsies showed that there is a clustering of megakaryocytes and there is abnormal localization toward the trabeculae. And reticulin showed a grade 3 fibrosis, and splenectomy had showed that extramedullary hematopoiesis with presence of megakaryocytes. And this is a case of a myelofibrosis. Then we had data of around 200 plus cases, and we tried to put it in a chart. Initially, when we put it in a chart, I couldn't understand how to make out. Same as with the IPF. Then we started plotting this in a box and whisker plot diagrams. We did for the ITP, megaloblast, aplastic anemias, acute leukemias, and this myelodysplastic myelofibrosis. Then when we see the individually, it is very difficult to make out that what is the increase and this thing at this thing. So we clubbed in one by one, one next to the next, and let me remove this platelet, this count dots here. Let it make it simpler. And there are a few cases you can see in the top. They are outliers. They are not counted in the statistical. Same as we did for the IPF. Then let me combine these together. You know, when we put it one below the other, the interesting findings came out. The ITP has got a low platelets and a high IPF. Aplastic anemias, the low platelets or the pancytopenia, but there was always a low IPF. Then megaloblastic anemia, we got a variable platelet count, but near normal IPF. Then acute leukemia, low platelets, normal IPF. The Sukesh sir, what he has said that they are always the early platelet because the amount of productions are reduced, but the release is same pattern, right? Then what about the myelodysplastic syndromes? We got a variable platelets, normal to high IPF. So we started using this IPF in a day-to-day practice so that this data, what we coming out is appears to be quite interesting. Then we just went to the literature. This is a South Korean article. They studied this thrombocytopenia and predicting the platelet recovery with the 5 of the parameters which has been extensively discussed. And they also added one parameter, that absolute immature platelet concentrate. And they came out with that this is significantly higher in hyperdestructive or consumptive thrombocytopenia, the same what we found. Then one larger study has happened in UK. They categorized these thrombocytopenia cases into 6 groups. They included the reduced thrombopoiesis, ITP, infection, hemorrhage into increased consumption, drugs, abnormal distributions like splenic sequestration, and they also included the platelet clump and satellitism as a one more group. And they found that this immature platelet fraction, they are increased in increased consumption category as well as thrombocytopenia. And this is a study done in Philadelphia. They included 127 ITP cases and 21 cases of bone marrow failure or the aplastic anemia. And the findings were exactly same, almost same as what we got in our study. The IPF there we got 16.6% as a mean, and we got 15.5. And in bone marrow failure or the aplastic anemia, they got around 2.9%. We got around 3.2%. And myelodysplastic, one interesting article also we came across. They got on 37 cases of myelodysplastic, and they had, again, the platelets are variable, IPF were also variable. They categorized into A1, A2 and B1, B2 based on the platelet number and the IPF numbers. And they came out that certain patients are having a high IPF level, and they explained that probably they are due to increased proliferation of normal megakaryocytes, or it can be atypical differentiations of the megakaryocytes. And in summary, we studied around 201 bone marrow cases as a cause of thrombocytopenia, and we divided into 5 etiological conditions, and we found that IPF is really high in ITP and is low in aplastic anemias. And with the introduction of CBC retic, IPF in peripheral smear and bone marrow has helped me to pick up a certain cause for this thrombocytopenia, and we could recommend or we could advise the bone marrow biopsy or aspiration at the earliest period. And this has helped the clinician for the appropriate treatment and so as to reduce the hospital stay for the patients. And this is how we try to connect the dots. We have data, we have peripheral smear, we have a CBC. You have to just look in all the parameters with the relevant clinical history and the bone marrow findings. We can connect the dots to the various etiology. And this is my take-home message about use this parameters in your day-to-day practice. Definitely it will help you. These are my references. Thank you.
So much. Yes, lots has been talked about, and we'll keep on talking about MPV and IPF. Any questions, any thoughts? Yes.
Very, very well presented. In fact, I'll say that you have taken the IPF to the next level and little away from dengue, which is very good. And you have studied the IPF in all the other bone marrow disorders now. Now, surprisingly, one observation that I've seen in your study is that in MDS, you find that the IPF is high to normal to high.
Yes.
And that's a surprise to us because in our cases, we have most of the times found that in MDS, the IPF is low. In fact, that used to give us the confidence to report it as MDS because we thought that it is going to be low. Now, there were 2 or 3 cases in which the IPF was high and they were MDS, so we were very surprised at why. Now, but I think we should have been surprised with the other way around, considering what you have found. But this is a new thing for us to figure out that the IPF in MDS is actually high, whereas we always thought it's low. So, but probably you've given the reason as mentioned in that paper.
They are mentioned in the literature. They are increased production from the existing megakaryocytes, or is an abnormal response from the megakaryocytes?
Yes, but most of our cases have showed us low IPF. I'll keep a follow-up of the...
Even we had a low platelet, but certain cases are very high.
So
they were disproportionate.
So in all these cases of MDS, has it been proven cytogenetically that they are MDS,
Yeah,
or is
not
it
all,
just the
madam.
morphology?
I think around 8 cases they have proven it.
Only 8 cases.
Yes,
Out of
yes.
how many
Out of
cases?
20. Out of 20. Yeah.
And rest of them are based on the morphological.
Yes.
And they have been treated like MDS.
Yes. And I clubbed both this MDS and myelofibrosis because I have got a data very less. Probably that is the reason that in my outcome there is a variable platelet counts. Let me check that only pure MDS, what will be there.
All right. I think we'll just do a follow-up on our cases also now. Thank you. It
Thank
was
you.
lovely.
Thank you, madam.
Thank you, Dr. Tadu. Thank you so much for your nice presentation. Any other question, comments? Yes, yes, please.
I was not going to after the intervention of the. I think I have studied MDS, also megaloblastic anemia, and other situations of ineffective erythropoiesis, and I have found that not all the MDS, but some MDS have high IRF and normal retics. That is defined as ineffective erythropoiesis, and the same with IPF. High IPF with low platelets. That is also, but not all of them. Will be interesting to know if the group of patients of MDS with ineffective thrombopoiesis and ineffective erythropoiesis respond differently to the therapies. And to do a clinical study, if these parameters have a clinical use, this fact, the ineffective thrombopoiesis and erythropoiesis have any value to predict the response to the therapies for MDS.
Yes, Dr. Rajesh.
Yeah, to your comment, means I can give you one additional thing. Some of the MDS patients have been treated with steroids and they respond very well. So are these patients who are having the high IRF and IPF, which are, so maybe we can do a study.
Thank you so much.
May I request Dr. Anil Handu to chair the session for Dr. Ramon?
Good afternoon, everybody. It's my proud privilege to introduce Dr. Ramon Simon Lopez. In fact, we have already introduced him in the last session that was yesterday. He is a clinician and a laboratory hematologist at the same time and has extensive work experience on hematology analyzers. And even currently, just about an hour back, he was actually looking at how will we have more studies on hematology analyzers, and I'm sure he's going to share with us something very insightful about chronic disease. All yours, sir.
Thank you. Yeah, anemia of chronic disease is a challenge for me, and this is the reason I was interested in to talk about that, because in my experience, it's the anemia that has less diagnosis or wrong diagnosis in the clinical practice. Because many GPs, when they have low iron, anemia, they give iron. If doesn't respond, more iron. Vitamin C. If doesn't respond, intravenous iron. Finally, when they don't respond, they do the ferritin. And the ferritin is 400, 500, and the CRP is high. And they realize that, in this case, they send to the hematologist. But it is a big problem. And I think it's a challenge, and we have to try to help the GPs to understand this anemia. First, let me define what is anemia. And I will remember again, because the WHO criteria for anemia is old, and we have found that many latent iron deficiencies, ladies that are working, some men, but ladies that are working, but have an hemoglobin of 12.2, 12.3, they have ferritin lower than 15. And they will develop anemia in the next months. But the criteria really has to be higher. And I recommend to use the WHO criteria that says that the criteria for anemia in men is less than 13.7 or less than 13.2 if you are more than 60. And for the ladies, less than 50, 12.2, less than 12.2, and not less than 12. Okay, and you can investigate that. You can investigate persons that are with 12, do the panel, the anemia panel, and you will find that many of them have a latent deficiency. And in the blacks, it's lower values, genetically, historically, or also maybe because they are protected historically from the malaria. The WHO did an experiment in Africa supplementing iron to all the people, and they got a lot of malaria deaths because iron deficiency protects from malaria. The experiment went wrong. Many people died because systematic administration of iron, oral iron in the food. I divided the anemia in the more common causes. And as we can see, iron deficiency anemia is 37% of the diagnosis of anemia. In a general population, the anemia of chronic disease is 27%, but this is not happening in the hospital setting. I did a study, and I recommend you to do, with 1,000 patients, randomly selected, no any criteria, only anemia, and I did to all of them B12, folate, CRP, iron, transferrin, ferritin, and I discovered that the leader was the anemia of chronic disease. When you do a systematic approach, and you use the criteria that transferrin has to be normal or low, ferritin has to be high, normal or high, you do all the criteria, you find that is the leader in causes of anemia. But let's begin with anemia. Of course, first is the blood smear examination. We try to get the best from the instrument, but yes, because we don't want to miss any abnormal case. But for me, the microscope is mandatory. I have 3 microscopes in my home. For this reason, I love microscopy. And the basis diagnosis for anemia, the first time you have to do a red blood cell morphology, moreover in cases with no clear diagnosis. And of course, when you see some of that you all recognize that, you have the diagnosis. Why to, investigate more? You have the reason for the anemia, and that is mandatory to do it. I obtained these slides from Dr. Juan Luis Vives Corrons, one of the best experts in anemia and hemoglobinopathies in the world. He passed away last summer, not this summer, the previous one, and he is my friend, even if he is not with us anymore. And I did this for everybody, that to teach all the people how to recognize the different type of red cells. Okay, I don't need to enter on that, but you will keep it and will be recorded in the video for teaching purposes. Okay, and how we can diagnose the iron deficiency anemia? I will go very fast if we don't need to. Low MCV for sure. Okay, higher DW is the best parameter alone to screen for anemia. A part of the research part of the CHR, hypochromic, but is the best parameter from the CBC to identify the anemia. The RDW is in a specific, low MCHC, red blood cells, RHE, reticulocyte hemoglobin for sure, and that is important because in these cases of latent iron deficiency, you find maybe the volume is still 80, 79, 81, but the reticulocyte hemoglobin is low. The new reticulocytes that are produced have hypochromia, but all the other not, because we have the average of 120 days. I am going to go fast because I want to spend my time. Of course, there are discrimination factors from England-Fraser to differentiate thalassemia and iron deficiency. Of course, CRP has to be negative, and I insist that, please, take home message. You cannot diagnose except in a lady that is healthy, bleeding, with metrorrhagias, but in all the rest of anemias, you cannot do a diagnosis of iron deficiency anemia without ferritin, or you don't have ferritin with a CRP that is negative, or inflammation markers like ESR, or other inflammation markers. You have to have a marker, a negative marker of inflammation. This is the important take message from this talk. Second, more frequent, and now is the time for my talk, but I am obligated to talk about iron deficiency because we are going to compare them. The MCV is normal, okay? But in 67% of the cases. In another 16.7 is a low. And we need to know that, okay? And another 16.5% is high. For this reason, we can have the three. Low MCV, don't exclude at the opposite. Have a big possibility, about 17% to have anemia of coronary disease. And I will recommend to see this plot. This plot and this article from New England Journal of Medicine, from Gunther Weiss, is the Bible of the anemia of coronary disease. It's becoming old, but it's still an article that we need to read, all of us. Please read it. Because also talk about ferritin. Ferritin more than 100, you begin to have a higher risk of infections. The reason the reference values of 300 are not true. They are 300 because the more common genetic disorder is hemochromatosis. And even you have a heterozygous hemochromatosis, you have a higher ferritin than 100. I did a study, random again, in women with hemoglobin between 12 and 13. And I did ferritin to all of them. All the ferritins more than 100, I did a study of hemochromatosis. 90% of these ladies have a gene of hemochromatosis when the ferritin was more than 100. Ferritin more than 100 is not normal, except if you have a liver disease, or you are alcoholic, or you have any other risk factor for that. But this is important because, as you can see, the differential diagnosis of iron metabolism disturbance, and now I am going to go for my stick, it's a biochemical marker of inflammation, is the first thing you need to do. And this is from New England Journal of Medicine, and this is from Gunther Weiss, recognized, is invited to the ASH meeting to give talks about anemia, is one of the more ethical and knowledgeable persons about anemia. The first is CRP. Not iron, not any other thing. CRP or any inflammation marker. Okay, after transferrin saturation and after ferritin. Less than 30, less than 30. I have seen reference values in many labs, 17, less than 17, less than 20, less than 12. No. You are including latent iron deficiencies in your reference values. No, are 25 or even 30, depending the laboratory, but never 12, never 15, never 17. And you divide the iron deficiency less than 30, ferritin between 30 and 100, anemia of coronary disease, and there is another option that is, anemia of coronary disease, and there is another option is the mixed anemia of coronary disease with iron deficiency. For example, a colon cancer. You are bleeding, you have a cancer, you have your iron blocked, and and finally you have also at the end a low ferritin. But you are giving iron and they only increase the ferritin. Only increase the ferritin. The serum iron begins the same and the hemoglobin begins the same, because you have lost all the deposits because the constant bleeding in the colon. And that is something that I recommend you to check. Here is the soluble transferrin receptor divided by the logarithm of ferritin. I am sorry, but I am against this parameter. Why? Divide the glucose of the patient or creatinine with logarithm of ferritin will be good for anemia of coronary disease. When you divide something by the logarithm of ferritin, even you can choose the creatinine. You will have a good diagnosis of anemia. But it's the ferritin what is important, not the soluble transferrin receptor. Soluble transferrin receptor is normal in anemia of coronary disease, and is normal in the iron deficiency anemia. When you divide it by logarithm of ferritin, it's useful, but it's a trick, it's a statistical trick. First thing I will destroy in my presentation, the coefficient. You have to do the transferrin receptor in the red cells. Yes, in the erythroblast. There you can measure with CD70, and you can, this is useful, the receptor in the erythroblast. What happened? In the anemia of coronary disease, there is an increase of transferrin receptor, but there is a decrease of NRBCs and retics. At the end, it's normal. You have an increase of the receptors per cell, but the soluble is normal, because you have the two-bone necrosis factor make that the total number of erythroid precursors is low. At the end, is normal. Normal retics, low or normal retic absolute number. High IRF, not in all the cases. but this is called ineffective erythropoiesis. Okay, and there is an increase of tumor necrosis factor, and there is that is what we found, and this is very useful. CRP for sure, or IL-6. That is even better. IL-6, as we will see in the graph from Gunther Weiss, is the precursor of epsilon. Epsilon is very difficult to measure. The urine is the best, but IL-6 is available. And IL-6 is the best parameter for inflammatory, better than CRP. Red hemoglobin, for sure. Hypo-RBC, that are both high in an iron deficiency anemia, in anemia of chronic disease. There is a low functional iron deficiency. Yes, but the ferritin will be normal or high. Okay? Soluble transferrin receptor is normal. Transferrin, this is very important again. Transferrin is normal or low, and that is very helpful. Transferrin is fantastic to diagnose anemia of chronic disease because it will be normal or low. CRP or IL-6 will be high, and ferritin will be normal or high. Pathophysiology, the article from Gunther Weiss. This is the best graph about iron metabolism. What happens when there are bacteria, okay, when there is cancer, when there is inflammation? That the liver provokes, here we have interleukin-6. Interleukin-6 go to the liver and produce epsilon. Epsilon close the release of iron from the macrophage. It makes that the iron is, all the iron that is available in the transferrin, in the blood, is accumulated in form of ferritin. And why? Why? Our body is doing that. Why? Our body provokes low iron, low transferrin saturation. Why? Because iron is very toxic in inflammation. Adds a lot of oxidation processes. Iron is very bad for the cancer. Cancer loves iron. Infections, bacteria loves iron. And our body is very intelligent and puts the iron in a safe place during the process, during the infection, during the inflammation, or during the cancer. If we insist and to give iron to this patient, we are putting wood to the fire of the cancer. We are putting wood to the fire to the infection, and we are going to put to the fire to the inflammation and creating superoxide radicals that will have damaged the heart, the arteries, will provoke a lot of side effects. Okay? Iron is bad in these cases, and the body is very intelligent. Listen to our body. And these are the pathways. Here I enlarge that. You know, the ferroportin is closed in case of the epsilon comes from the IL-6 epsilon. The ferroportin is closed. The ferroportin is the door that permits the release of iron. And also the iron is absorbed from the serum to the macrophage. And the macrophage keeps the iron in a safe place that is not damaging us. I will show you a very interesting article that was not made for my purpose, but is very useful for my purpose. Dr. Gunther Weiss gave me a visit from me to Austria, to Innsbruck, where he is working. And I need the stick for that. This was a study in hemodialysis patients. He chose similar groups. A group in hemodialysis that he was going to give erythropoietin and iron, and a group of hemodialysis with only erythropoietin, no iron, to see what happens. Both have similar age, both have similar ferritin, 300, okay? Both were very similar. And look what's happening. He was investigating how the iron affects all the interleukins and the POX and how it was affecting the iron. And here you can see the group of 0, no iron, and the group of 1, iron. The more amazing for him, look, the group with no iron, the ferritin was decreasing during the time till 160. The group with iron, with establishing the dosage exactly how the Kadoki said, was increasing with the time till 556. But look the hemoglobin in both groups, 12, 12, 12, 12, 12, 12, 12, 12, 12, 12, with no any significant difference. In this case, why we need iron? We don't need iron if the ferritin is more than 150. Only erythropoietin. And that is the lesson we learn. We don't need, even if the transferrin is low, because believe me, look, the transferrin saturation in the group of no iron is increasing. You know, in the group of no iron is 18. In the group of iron is 38. You know, here, you know, the transferrin saturation shows that there is a lack of iron, but the hemoglobin is the same. Why? Something that was discovered after that, erythroferon. The erythropoietin, due to erythroferon, EFE, is able to liberate the iron by itself from the macrophage. The erythropoietin, thanks to the erythroferon, is liberating the iron it needs for erythropoiesis, and you don't need to give intravenous iron. And the group without iron, for 3 months, was keeping the same hemoglobin. The article of Gunther Weiss compared the anemia of chronic disease and iron deficiency. Look, iron, reduced, transferrin, reduced, increase in iron deficiency. This is an important point. But transferrin saturation, reduced. What the GPs do? Low iron, low transferrin saturation, iron. We need to convince them to do an inflammation marker every time we have an iron deficiency, first time. Okay? Cytokine levels, IL-6, increase and normal. And that is the schematics for the diagnosis of anemia. I recommend you to have a look in this article from the New England Journal of Medicine. The treatment of the iron deficiency of the anemia of chronic disease, the treatment of the underlying disease. If it's less than 7 the hemoglobin, transfusion. But never give iron. The patient have iron. In my experience, you can give as much iron as you want. The serum iron will be low. The transferrin saturation will be low. Only will begin serum iron and transferrin saturation when you are arriving to levels of 800 of ferritin, 700. Till this moment, is still the same because the body is putting all the iron you are administrating to the macrophages. This is the study showing the erythroferon contributes to the recovery of anemia of inflammation. And erythropoietin liberates erythroferon. This is the way to liberate the iron. Only give erythropoietin in hemodialysis or in any situation, except in tumors, because some articles have said that solid tumors, erythropoietin can stimulate the growth of the tumor. That was famous, and is not indicated if you don't know if it's stimulating the growth of the tumor. And that is published in Blood in 2014. Another very important article that destroys the concept that I have heard many times, that says that the ferritin is an inflammatory protein. Okay? And everybody mentioned, yes, it's an inflammatory protein, but without iron. I was reviewing all the references, and finally all arrived to Carlo Brugnara from the Children's Hospital in Boston. Okay? He never showed any proof of that. He said, and everybody repeated, Auerbach, all the popes of hematology, but nobody demonstrated never that the patient with high ferritin don't have iron. But Gunther Weiss and Dr. Hall, in this article, they demonstrated the opposite. You cannot do a biopsy because nobody will authorize you to give biopsy to a hemodialysis patient. But they did another method. They were sorting monocytes from the blood in anemia of chronic disease, and they were measuring with atomic absorption the iron of the monocytes. And they have demonstrated that in anemia of chronic disease, the iron was very high in the monocytes of the anemia of chronic disease and not in the control group. The ferritin correlates with iron. After that, I was going to Dr. Razmilevich, famous doctor, passed away. But in this time, after one speech in the ASH about myelodysplastic syndromes and the treatment of anemia and erythropoiesis, I was challenging him to demonstrate my theory. We were putting in the table $100. Who is right, me or Brugnara and Auerbach? And he did the study in his hospital in Israel. He was following Brugnara.
every transferrin saturation low, every hypochromic red cells or CHR, intravenous iron and intravenous iron. Look what happened, and I was participating in this study, as you see. Look the patient how they were. 6,800 ferritin, 5,500. He was shocked when he saw that. They were not controlling ferritin because they said it's an inflammatory protein. It's useless. Don't contain iron. Okay. We were looking the patients repeating the study of Weiss. The patients only with erythropoietin, with no iron, the ferritin was decreasing, decreasing, decreasing with normal hemoglobin. During 1 year, they become normals of ferritin. All the patients that have very high ferritin. During 1 year, only erythropoietin, and was working. Okay, and here the T2 star demonstrating the iron overload in all of them. It was iron overload, similar than sickle cell anemia with multiple transfusions. And we have the test. We were checking the T2 star, demonstrating that the T2 analysis shows an accumulation in the liver, in the spleen, and in the pancreas. This ferritin contains iron, my God. But this lie, sorry, it was a lie because never was demonstrated that the ferritin is an inflammatory and don't contain iron is not true. For hemodialysis, we only need to keep the ferritin more than 150. That's all. Give iron when the ferritin goes down of 150. Doing that, you will keep the hemoglobin normal. Give the folic acid because they need folic, they need other things, but don't give iron to the anemia of chronic disease, even in hemodialysis. How to utilize the different tests in the anemia differential diagnosis? I will pass very fast because my time is up. I was using in this study of 1,000 patients all the hematological parameters. And in anemia of chronic disease, as you can see, nothing was high, nothing was low, was not useful. In iron deficiency, yes. Their DW was very high. In using the reticulocyte parameters, in anemia of chronic disease, we only see a high IRF. That's all. That's all. Okay? The retic percentage normal, but this is useful. This is called inefficient erythropoiesis. The only thing that is useful. And finally, I decided to use CRP and ferritin. Here, I have a difference. Here, I have a difference. We don't have to divorce from the immunochemistry. They are our friends. We have to work together. We are better together. IL-6, ferritin, transferrin, CRP, why not? We don't have to do everything ourselves. We need to flag, we need to forward, to reflex, but we need them. We can assess the functional iron deficiency, yes. We don't have iron available, yes. Hypochromic red cells, CHR, perfect. But we need to do an inflammation marker and we need to check immunochemistry. Summary. It shows iron deficiency, erythropoiesis, just a few days. You know, I will go. This is a summary of the parameters. I will go. Okay, important. Summary. For iron deficiency anemia, MSCB is low, hypo-RBC is high, soluble transferrin receptor is high, reticulocyte hemoglobin is low, discrimination factor differentiated from thalassemia, and CRP is negative. Okay? Anemia of chronic disease, reticulocyte hemoglobin low, similar to that. Ferritin is, sorry, this is a mistake. Sorry. High or normal, a mistake. And CRP, IL-6 is high. And that is the important thing. Thank you. Any question?
Interesting presentation, and you have tried to explain to us the intricacies of the mechanisms that are interplaying in a patient of anemia of chronic disorder, and which component is contributing in what way is also that you try to touch upon. which of these parameters or components or mechanisms is operating at a given point in time is also something which you highlighted. My question is, you did mention about anemia of chronic disorder with iron deficiency. I have done some studies in that area as well, and what I found is that patients who have coexistent iron deficiency in anemia of chronic disorders have higher serum transferrin, soluble serum transferrin receptor than the ones which are not having iron deficiency. So what is your, you did refer to that. Do you therefore suggest that this can be taken on face value and the patients who show high transferrin receptor, patients of ACD showing high transferrin receptor would benefit from some kind of therapy, additional management which will supplement the iron while you are treating the anemia of chronic disorder?
To supplement the iron in anemia of chronic disease?
No, with iron deficiency.
Or with iron deficiency? Anemia of chronic disease with iron deficiency. It's the same. Normally, the only difference of anemia of chronic disease with iron deficiency and anemia of chronic disease is that the patient has lost, for any reason, iron. Yes. Normally it's a bleeding, and but the situation is the same. There is a cancer, or an inflammation, or an infection. Yeah. And in the three situations, the iron is toxic for us. For this reason, in this case, we need to, as is recommended, treat the cause of the problem. We need to treat the infection, the inflammation, or the cancer.
But not interfere with the...
We can give erythropoietin alone, but except in cancer, because it has demonstrated that in solid tumors, erythropoietin can increase the growth of the cancer. It's not a specific erythropoietin for red cells. It also looks like solid tumors have a receptor of the erythropoietin. The more important is it's very simple. Every time we detect iron deficiency, with all these parameters, immediate with reticulocyte hemoglobin, at the long time with low MCV, hypochromia, low MCHC, in any way, please, it's a simple CRP, sedimentation rate. And if you want to do it better, IL-6, because it's the precursor of hepcidin, and I recommend to do IL-6. But don't do anything else till you have an inflammation marker. With a positive inflammation marker, you are obligated to do ferritin, and you are obligated to do transferrin. And reticulocytes, because you have also see if there is an ineffective erythropoiesis. But the take-home message is never diagnose anymore an iron deficiency without a negative inflammation marker. Never more. Because that is, in my opinion, a big problem in hematology today. Not for you that you are expert, but the GPs, we need to activate always, when there is an iron deficiency, first time, inflammation marker.
In patients of chronic renal disease, it's a big challenge. Renal patients, yes. Renal failure, patients who are on repeated dialysis. Assessing their iron status is also very problematic, because serum iron will be low, transferrin saturation low. Ferritin may not be very high, but what would be your cutoff for ferritin?
150.
How much?
Between 150 and 250, that's all.
That's it. So if it crosses 100 and 200, then would you recommend iron in such cases?
No, and this is demonstrated in several studies now. Because now other groups in France are doing, but we have against the FDA. FDA only reimburses erythropoietin if you give intravenous iron together.
Yes, that is the point.
I know.
Because they don't give erythropoietin.
I know.
They give iron with it.
I know.
Now, if we report the ferritin high, then they wait till the ferritin comes down with EPO. Otherwise, they give iron with EPO. Now, the challenge is, what is the level of transferrin saturation, or should the transferrin soluble receptor be done? Do you think, will it help us?
Soluble transferrin receptor is useful only when you are having of mixed anemia of coronary disease and iron deficiency.
And iron deficiency.
When you have a high CRP and the ferritin is borderline 25, not low, not high, there you can do soluble receptor, okay? But I will never divide by logarithm of ferritin. I will divide by the absolute number of retics, as somebody proposed here to divide something by the retics. I don't know, remember which parameter, but this was the ideal, not by ferritin.
Okay.
If you divide creatinine by ferritin, will be useful for anemia of coronary disease.
Okay.
And the lesson is, yes, every hemodialysis patient, you would have to give EPO and only keep the ferritin between 150 and 200, 250. But if it's possible to keep it between 150 and 200, remember that Dr. Turl said that more than 100, you begin to have an increase of infections, statistically significant.
Right.
Therefore, the reason is better to have the ferritin lower than 200, but 6,000. These patients have diabetes related to the hemochromatosis. Right. They have a lot of side effects, infections, death. How many deaths, people? Because this lie of the ferritin is an inflammatory protein. I agree. It increases with inflammation, but contains iron.
Yeah.
And now it's demonstrated.
So only if the ferritin is less than 100
with
EPO, then you give iron. Is that right?
No, we need to give iron to keep ferritin between 100 or 150, better, you have margin, between 150 and 250. Only keeping that. When it's more than 250, stop iron.
Agreed. Okay.
This is my recommendation.
But
and now,
EPO can be continued. EPO.
EPO always.
Can be continued.
EPO always, because the kidney is not producing any more EPO.
Yeah. Thank you. Thank you.
Oops, my stick. That was something to clean the floor.
Again, in chronic kidney disease, we tend to do a lot of bone marrow and they tend to be hypocellular. They are on EPO, but if we see the iron content in the bone marrow is 0, grade 0, no storage iron, then I guess in that case, iron should be given even if the ferritin is very high.
You know, the same value of ferritin is bone marrow biopsy.
Because most of these cases we have seen ferritin is very high. Sometimes more than 1,000.
If the ferritin is very high and you say in the bone marrow is low,
yes,
I never seen
storage
that.
iron is 0.
I never seen that.
Okay.
I never seen that. If you have one case, please give me, because I will investigate that. I never seen a case with high ferritin and no iron in the bone marrow.
Okay.
If you have it, please share with me, because that will make me begin another study demonstrating that. I never seen that.
Okay.
If you see that, please share to me.
Sure. Thank you.
Yeah, we need facts.
Ferritin being an acute phase reactant, it will rise first in the serum, as we understand, before it is stored in the bone marrow. Am I right to interpret it like that?
You know, but what I believe is every time that the ferritin is high, we have to find with the pearl stain iron in the bone marrow. If not, we need to investigate that there is a mistake in the stain or anything, but we need to investigate it, because according to this theory, and it's supported not only me, Dr. Hall, now very groups of French people, Dr. Toll, Dr. Hall, Dr. Gunther Weiss, that ferritin is always coming with iron. High ferritin is always coming with iron. If anybody finds the opposite, please contact me, because we will investigate why, and we have other techniques to see if there is iron in the monocytes or iron in the macrophages with other techniques. But please share with me if you find any case.
We would like to look at that, because
absolutely.
Once the serum ferritin is high, we don't do a bone marrow.
No?
Normally in these patients, unless you're suspecting some cause for renal failure like myeloma or anything else, we don't do a bone marrow. But she's right, in patients who are not responding to EPO, erythropoietin, they ask for a bone marrow.
No, yes, it's true,
Yes.
because can have other reasons, other causes.
Yes.
But I never found with high ferritin no iron in the bone marrow. I never.
I think we'll start looking at high ferritin and do a bone marrow in those patients. Let's see what we can find. Good food for thought.
Very good.
Aditi Mittal is a new entrant in the field of hematology, from the profile that I see on the screen. She did her MD pathology from Sri Ram Institute, Medical College in Bareilly, and completed her fellowship in hematopathology from B.L. Kapoor, obviously with Dr. Handu. She has done publications in national and international journals, which will happen when you work with people like Dr. Handu, of course, but not to take away any credit from you. And she is a member of Delhi Society of Hematology and the Cytometry Society of India. And she is currently working as associate consultant in hematology at B.L. Kapoor, Max Super Specialty Hospital in New Delhi. Aditi, welcome, and we look forward to hearing from you something new. I don't see the subject of your presentation, but a topic, a comparison of platelet count on hematology analyzers and digital morphology.
Yeah.
A very exciting prospect here, and look forward to hearing you.
Thank you, sir, for the introduction. I would like to thank to my mentors, Dr. Anil Handu sir and Dr. Tina ma'am, to give me this opportunity to bring forth my research in front of everyone. So I am talking about the correlation of platelet count by optical and impedance method on Mindray BC 6800 plus and the platelet count by digital morphology. So platelet count has always been a controversy among all the doctors, and because the patient management depends on the platelet count, and we want to give the platelet count as accurate as possible, as quick as possible. So the assessment of platelet count is essential in both clinical hematology and platelet research laboratories, and any numerical deficiency or defect in their function may lead to bleeding. So in severely thrombocytopenic patients, the accuracy of the platelet count is of utmost importance, as the count is used to determine if the patient requires platelet transfusion. Especially in the dengue time, it becomes very essential. So they need no introduction. They brought a revolution in the blood counting by giving Coulter principle to us, and later platelet count were added to the automated blood count in late 1970s. But till now, we have come so far, and ICSH first gave phase contrast microscopy as a standard for platelet counting. Later on in 2001, it suggested flow cytometric platelet counting as the reference method using RBC and platelet ratio by using CD41 and CD61 antibodies to identify the platelets. So, but it has its own limitations because it is an expensive test, labor intensive and time consuming, and requires a skilled person. So not every laboratory can afford to apply flow cytometry counting for the platelet count in every case. And there are other techniques of the platelet counting, like direct methods by hemocytometry and microscopy, indirect methods in which red cells were counted directly and their proportion to platelets determined in a stained blood film. Semi-automated methods in which counts are performed electronically using PRP, and fully automated methods. These today automated analyzers have come, and they make this platelet counting little easier by using following methods: impedance method, optical fluorescence method, and the immunological method. Not going into detail of them, I think everyone knows about them. But still, we still get a call that yesterday you gave the platelet count of 250,000 and today the platelet is just 14,000. Can you give us a manual platelet count? Or you can confirm the platelet count is 10,000, is it really 10,000? Can you confirm it by smear? So we still rely on our blood examination manually on the stained smear, and it is very useful, especially when the platelet counts are spuriously low in cases of EDTA-induced platelet clumping or platelet satellitism. Also, it also helps to detect abnormal morphology of platelets, which can indicate to certain diseases like small platelets in Wiskott-Eldridge syndrome, or large platelets in some chronic myeloproliferative disease and Bernard-Solier syndrome and macrothrombocytopenic cases. So the aim and objective of my study is to correlate the platelet count by these methods, optical and impedance, and correlate it with digital morphology and manual smear count. So we took 1,000 patient samples, both IPD and OPD, and from June 2023 to August 2023, and the age range was 2 to 80 years with no significant male to female preponderance. And platelets were analyzed in Mindray BC 6800 plus. Both impedance and optical modes were run, which is CD and CDR modes, were run on the analyzer. And then we have auto stainer of Mindray SC120, and the slides were stained in it. And the manual smear counting was done. And then the sample was also run on the digital morphology analyzer, Mindray MC80, and also platelet count was determined through the digital morphology. Here we used manual smear counting as our gold standard because we can't put, because of the cost strains. So we took manual smear platelet count as our gold standard and compare it with each of those methods. So the microscope used was Nikon microscope 80i, and the platelet estimate factor was used for 10,000. So how did we calculate this factor? So we take 1,000 cases of unflecked normal platelet count, and then smears were processed in Mindray BC 6800 plus and stained by Mindray SC120, and number of platelets in each oil immersion field for each case was determined. And then flow cyt, although we did flow cytometry in few cases, like 20 cases, and correlate with the manual smear count as well. And based on which average number of platelets were calculated and our factor was determined. So the analyzer used in the study was Mindray BC 6800 plus, in which CD and CDR modes were run on each sample, and we got impedance and optical platelet count. This is a SC120 slide maker stainer. It can stain up to 180 slides per hour. So it's also time saving. And the blood volume, according to the hematocrit of the volume, it can adjust the spread of the smear, and the protocol used at our center is Wright Jinsa. And the sample volume taken by this 200 microliter. Then a new advancement in technology is coming these days, and digital morphology has changed and make it more convenient for us to give the platelet count as quick as possible. So this is Mindray MC80 analyzer workflow, and it take almost 5 million photos of all WBCs, and almost take 3,500 scan 3,500 fields and give us 2D images. And on the basis of it, suppose this is an example that I run a sample, and we get WBC. It automatically divides the counts in WBC, RBC, and platelet. And in WBC chamber, it gives like this, and RBC it gives images and segregates them in different. And in platelet, there are two modes. So in auto mode, this digital morphology analyzer counts automatically by itself, and it gives us the count. For example, in this case, the platelet count was by impedance method was 1,02,000, and platelet clump was flecked. So I also looked at the smear, and I found no clumps, and the platelet count was almost 1,40,000. Digital morphology analyzer in auto mode gives 1,38,000. Then it also give you the way to manually count on the images by yourself. So there is a manual mode, and you can count the platelets in each image, the boxes given below, and based on that, it automatically calculates the platelet count. So after manual counting on digital morphology, it was 1,42,000. However, no clump was flecked. So in our study, we took the samples with platelet flecks. We include the samples with platelet flecks like thrombocytopenia or platelet histogram abnormal, platelet clumps, or R-fleck for review. But for platelet, especially in case of platelet clumps, there is a mode in the digital morphology analyzer, which is pro-platelet mode. So like in that case in which the clump was flagged, and I got 1,42,000 on digital manual mode and auto mode 1,38,000. The sample was run in pro-platelet mode as well. It uses its high magnification objective lens to scan the body, edges and tail of the smear to locate and identify the platelet clumps. And this is how it looks. So it detects 4 tiny platelet clumps in the platelet pro mode, which could be missed, which was missed while doing the manual smear examination under the microscope. So in our study, we compared all the methods with like automated method by digital morphology, manual count by digital morphology, impedance method, optical method, manual smear count, and flagging versus pro-platelet mode. And we calculate the mean by every count, every method, and calculated the mean, and we found that if compared to manual smear count, the average mean of optical, average mean of manual digital count was closer to the manual smear count, followed by the optical method, and then automated digital method. And impedance has the least correlation with the manual smear examination. Then we also calculated the Pearson coefficient for each method. So in automated digital versus manual, if we see the graphs, there were not so much outliers. If we see the graph, and the Pearson coefficient was 0.95. For manual digital versus manual method, manual smear count was Pearson coefficient was 0.97. Then impedance versus manual, Pearson coefficient was 0.94, and optical versus manual, Pearson coefficient was 0.98. So when we tabulate that data, we found that manual digital was there was the best correlation between the manual digital method, manual count by digital morphology, and manual smear examination, and under the microscope, followed by I think optical method, which was 0.98. So they were the closest, which were to the manual smear counting, and impedance has the least correlation with the manual smear counting. Then we also compared the pro-platelet mode with flagging of platelet clump. So all the 1,000 samples, we found that pro-platelet, when the sample was run in pro-platelet mode, the sensitivity and accuracy has increased from 92.6% to 100% and 90 to 92% respectively in pro-platelet mode. So this might be a clue that pro-platelet mode has better sensitivity, is a better way in the coming time to detect the platelet clumps. Also, there were 3 outliers in which the 2 of the cases there was no flagging. However, both manual smear examination and digital morphology pro-platelet count detects the platelet clumps. And in one case, there was neither flagging or no platelet clumps detected in the manual smear examination. However, pro-platelet mode in Mindray MC80 analyzer detected 2 platelet clumps. So again, it is indicating that pro mode is a better way of detecting platelet clumps on digital morphology than smear examination, and it is well correlated with the flagging given by the analyzer. Also, there was only one study in the literature which the use of Mindray and C80 digital morphology analyzers estimated platelet count, and they also found the similar results as us. And so to conclude, that optical method is the most accurate method of the platelet counting when correlated with manual smear platelet examination. So simultaneous measurement of platelet count by optical and the smear examination can give us the more accurate platelet count results, followed by digital morphology can make it easier and less time consuming because it takes time to stain a slide, and digital morphology scans a slide in just 1 minute, and the staining time by the auto stainer is just 15 minutes. So in 15-16 minutes you can calculate the platelet count, and it is almost as accurate as manual smear examination under the microscope. And impedance has the least correlation with the manual smear platelet examination, and pro-platelet mode has definitely the higher sensitivity and accuracy of detecting platelet clumps. Thank you.
Thank you, Dr. Mittal, for bringing out a very important message. And I just had a clarification from you. I would like to seek a clarification. And that is, when you are talking about manual platelet counting, you are talking about platelets with respect to the RBCs. What is your
I'm
smear?
manual smear count. Manual smear count.
No. So how are you counting? I mean,
So
with
I am
respect to
counting.
what is your benchmark?
So I'm counting 10 fields, counting platelets in 10 fields, and the platelet estimate factor for our microscope was 10,000. And so, like in one field, whatever the platelets are counting is multiplied by 10,000.
Over impressed by the accuracy of that manual way of counting, because we know it has its own limitation. It is not a actual enumeration of the
Yes, sir. So that's why we did flow cytometry counting also in just 20 cases, because we can't do, because of the cost strains in all the cases, and try to see that almost as same as manual counting. And in usually routine practices, we rely on our manual platelet count only.
That's true, but that is somewhat like an estimate. It is not a
Yes.
true count. And therefore, as I said, I'm impressed by the correlation you're finding with the optical platelet count and the manual, digital, or actually manually done. So that is just an observation, and if that's the case, then I think manual counting would replace, in many labs, platelet counting by even the analyzers. So there's something to ponder about. I mean, just an observation, but it's a very beautiful presentation, very good work, and I think there would be some more comments.
Thank you, sir.
Aditi, very good, well presented and thought about.
Thank
but
you.
when we talk of manual platelet count,
yes,
we were talking of the old gold standard, which the
Phase
International
contrast.
Society had taken.
Yeah.
The Brecker's method, which is 1% ammonium oxalate,
Yes,
and doing the chamber count.
Yeah.
Yeah.
Sir.
And this method, what you are describing on a smear,
Yeah.
is on a EDTA smear.
Yeah, yes.
It cannot be done on a fresh smear, first thing.
Yes.
And we know that EDTA smears have little bit of fallacy of EDTA clumping.
Yes, sir.
So you have to see that your analyzer has not given you a flag of clumping.
That's
and
why
only-
the pro platelet mode is there.
Yes, and
Yeah.
only in those cases you can compare your slide count
Okay.
with your other count.
So we ran pro platelet mode in every case.
Yeah.
And we also saw the slide for clumps in
Yeah.
every case under the microscope, and also on the pro platelet mode on digital morphology.
Yeah, because Brecker's method using 1% ammonium oxalate can be very tedious,
Yes, sir.
cannot be done practically,
That's
but yes, very high CV, but still in our lab, when we are comparing or actually confirming the lower counts, we are doing morphology with manual Brecker's method as well. But good, because you have to be little careful when you're giving a slide count. I know, and it has to be counted in an area where there is just no overlapping of arms.
So the pro platelet mode, it scans the slide towards the tail and the edges of the smear only, so that no clump, because clumps mostly found on that area.
Yes.
So it almost scans various fields to give us that there should be no clumps left, or if there are any clump, it highlights it.
Very good.
Thank you.
Nice, saves time. Yeah.
Just one short comment on the flow-based assay.
Yes.
Some of us who have worked in that area will tell you that the assay doesn't take care of the issue of platelet aggregates.
Yes.
It is blind to that. And in flow cytometer, aggregates would tend to get excluded once you put the gate, because they assume different size and granularity. And therefore the count, although it is touted to be a very accurate count and gold standard method and all that stuff, but people who have actually worked with this method will tell you it is not so rosy as people tend to project it to be. And as you rightly mentioned, others have also mentioned, it's not a very practical way of doing the count on a day-to-day basis, because it's also expensive. So just share, I was thinking of sharing this thought with you and for the general audience. Yeah, sure.
When you were doing the manual counts, what were the areas that you were actually doing? Like ma'am said, the selection of the area where you
Towards the
see
tail, where the RBC are just lying,
the tail is a
sitting
very
next to
big
each other,
area.
not overlapping
Plus,
it.
smears when you make, every smear is different. I mean, no two smears will be similar and no two smears will have similar kind of area. So there's a lot of manual variation
So the
in making of
smears,
smears.
on which we did the platelet counting was stained by Mindray analyzer, auto stainer.
That you're talking of the analyzer stainer, but your manual count when you're
That
doing
was done on that stainer.
stainer
So they
only.
were
Okay.
evenly spread.
Okay.
All the slide were evenly spread by the auto stainer. That's again an advantage of the auto stainer, that it according to the hematocrit, it automatically adjusts that angle and evenly spread the slide.
Slide.
So that was the
Because I think there is a difference between what manually we are doing. I think the
So the
count
manual
is
smear count was done on stained smears, on the smear stained by auto stainer.
on manual made smears. I think it is, we have the count factor of 15,000. That's where I think I differ with the, or maybe the selection of the areas is different with
because this estimate factor is based on the microscope we use, on which we counted the platelet in the microscope at Nikon 80i, and it was 10,000 for our microscope.
Okay. In our here, I think we use 15,000 as a.
Thank
But
you.
yes.
Thank you, Asim. I think we'll stop here.
Actually,
There are some
I just wanted to
questions.
clarify that point of it, what you were telling us, ma'am.
Yeah.
When you decide what is the factor that you will have for your laboratory, it's heavily dependent upon the area of your microscope and the way the smears are made. So if I have 10,000 in my lab, it is not necessary that in your microscope, in your lab, it will be 10. There it might be 12 or maybe 20, and maybe in somebody else's lab it might be about 8,000 or 7,000. So it will be variable. That's why when we decided to determine the factor, the idea was take the benchmark. What is your benchmark? Benchmark is flow cytometry. So do flow cytometry on 20 samples, get your platelet counts from there, compare the counts which have come from the hematology analyzer, look on the smears which has been defined, designed and developed on the auto analyzer, not by you by hand, so that there is some degree of uniformity. And then when you take the ideal zone, figure out in that ideal, so-called ideal zone, as to how many platelet points did you get. And then basis that gave you some degree of standardization. Of course, when you're going to be doing things manually, just as the way what we're talking, the CV is definitely going to be higher. We're not talking about flow cytometry here. We're talking about something which will have probably a CV of maybe 10, 15, 20%. But with that part of it also, if you take it, in any case, as a routine, if you look at hematology analyzers, how do you verify your counts when you are running the samples on a CBC analyzer? You verify them by looking on a smear at the end and just checking out, grossly. That, okay, the platelet count might be about 1 lakh, or this platelet count doesn't look like 1 lakh when you're comparing it with the impedance. So keeping that in mind, we looked at this study and thought, let's see what digital morphology tells us, and how does digital morphology come up and give us the pickup of all those clumps which we may otherwise miss even when we are seeing a smear. So that's where pro-platelet mode seemed to give us a better result. This was more of an observational thing. We will be expanding it further and trying to see with respect to the standard methodology, and we'll come back to you with that.
It is too impressive, Anil, comparing manual and finding such an excellent correlation with the automated counting. That is something which is, if proven through a larger study, is a very important information. So, okay, so I think we'll stop here. I think we have had a lot of discussion on platelets every day, almost in all sessions, but these are all very enlightening discussions, because on one side, it is also very satisfying and gratifying to learn that we are progressing, forward in the ways of doing better counting. At the same time, highlight the challenges that we still face or are remaining to be addressed. So I think
And
that's
it also
excellent.
gives you an option to convert all the images into PDF. So if you are not in the lab, your technician can send you the whole PDF or the picture
those
and you can
advantages
see
are
it from there.
Yes, 100%. Okay, thank you. I think we'll stop here. We'll have to stop here today.
It's just to comment that the MC80 have a special mode that can check for the edges and the borders to check for platelet clamps. If the platelets are less than 150, you can check a special mode that check the edges for looking for the platelet clamps, because I agree, some samples don't have a clear pseudothrombocytopenia, but have some small clamps. And this is the reason it was created, this software for that.
It's a new development. Yes, thank you. Shama?
So,
Thank
you, sir.
Thank you all very much.
Dr. Rajalakshmi, the next speaker, Dr. Rajalakshmi Rajshekhar. And may I request Dr. Manjunath to chair the session, please?
It's my great pleasure to introduce Dr. Rajalakshmi Rajshekhar. I am very happy to say that she was my MBBS student also at JSS Medical College. She is the 4th rank holder in MD Pathology from Rajiv Gandhi University of Health Sciences. She did her MD from Mysore Medical College. She has 14 years of teaching experience. She is trained at Tata Memorial Hospital, Mumbai in hematology. She has 18 national and international publications on her name. She has participated as a panelist in panel discussions, presented in oral papers in state, national and international conferences. Over to Dr. Rajalakshmi.
Thank you, sir, for your kind introduction. At the outset, I would like to thank the organizers, Mindray and BLK Max Super Speciality Hospital, and my principal institution, and Dr. Deputy Director of Laboratory Services, Dr. Manjunath, who is here, and my professor and HOD for this research, which is possible now, and I'm able to present it here in the forum. I would also extend my special thanks to Mr. Biju, Application Specialist from Mindray, for the acquisition of data. So today I am presenting automated FRC count in Mindray BC 6200. That is the instrument we have in our institute. So here the study was to evaluate the effect of microcytosis and poikilocytosis on the automated counting, that is automated FRC count in the Mindray analyzer. So schistocytes, which are formed after mechanical intravascular destruction of erythrocytes, are major signs of micro and macroangiopathic hemolytic anemia. All of us know the causes of micro and macroangiopathic anemia, so I'll just move on to the next slide. So there is a recommendation by the ICSH, the International Council for Standardization of Hematology. So the guidelines in 2021 update says the recommended reference ranges for healthy adults and full-term neonates as more than 1%. More than 1% of morphologically identified schistocytes on the blood film are considered suspicious for thrombotic microangiopathy. Whereas for preterm infants, the count is suggested, recommended by ICSH is more than 5%. So this ICSH has defined schistocytes as always smaller than intact red cells and can have the shape of fragments with sharp angles and straight borders, small crescents in the form of helmet cells and keratocytes. So these are counted under oil immersion microscope, oil immersion objective. Minimum 1000 RBCs are counted, and even then we can find inter-observer bias. So the fragmented RBCs are also generated by the autoanalyzers, hematology analyzers nowadays, and there is a suggestion that the absence of FRCs can be used as a valuable parameter to exclude the presence of schistocytes on the blood film. So coming to the principle of FRC detection in Mindray BC 6200, this is evaluated in the red channel using a fluorochrome fluorescent dye. So that stains the ribosomal RNA of the reticulocytes. Forward scatter in this red channel, diff scatter plot, it shows the blood cell size, while fluorescence intensity displays the RNA content. So this is well known. And the FRC as depicted in this representation is between the reticulocytes and the platelet, optical platelets which are measured. So this is the window for FRC, which is highlighted there with a dotted circle. So these are the values which are given by the RUO parameters, that is research use only parameters by Mindray, which gives the FRC, that is fragmented red cells, in absolutes as well as percentages. So the estimation of FRCs by analyzers warrants a mandatory blood film analysis after the FRCs are flagged by the analyzer and the count is given by the analyzer to assess actually the real count of the FRCs. The conditions presenting with microcytosis could influence automated FRC count exhibiting a false high FRC value. And this was inferred after observing some of the slides, some of the cases of microcytic hypochromic anemia where there was flagging for fragmented RBCs and the FRC count approximately nearing to 1% was given by the analyzer. So a literature search was done where I came across a study where there was interference of microcytosis, where there was a study on the interference of microcytosis and hypochromasia on the Sysmex analyzer. The result was just that, there was no interference of microcytosis, whereas hypochromasia did interfere with the automated FRC counting. Whereas there were no studies available on the interference by poikilocytes. So this study was taken up to evaluate the accuracy of automated FRC estimation in hemolytic anemia by the analyzer in the presence of microcytosis and anisopoikilocytosis. So the objectives were to evaluate the accuracy of automated FRC counting in hemolytic anemia compared with the manual method and to assess the interference of microcytosis and anisopoikilocytosis in automated FRC counting. So a total of 76 cases of hemolytic anemia were included. Among these, 47 cases were extravascular hemolysis, 29 cases were intravascular hemolysis. A control group of 86 normal subjects were also taken to look for the FRC and other parameters in the analyzer. And then a group of 73 cases of microcytic hypochromic anemia were also included in the study to look for the interference of microcytosis and anisopoikilocytosis with FRC counting. All these indices were acquired from Mindray BC 6200. So the results were the 29 intravascular hemolysis cases comprised of MAHA, that is microangiopathic hemolytic anemia, 1 case of definitive TTP, 2 cases of HUS2, G6PD deficiency 5 cases, cold agglutinin induced autoimmune hemolytic anemia 15 cases, and then extravascular hemolysis thalassemia, sickle thalassemia combination and sickle cell anemia, hereditary spherocytosis, elliptocytosis, and 4 cases of autoimmune hemolytic anemia, WORM. So this is the scatter plot that was obtained from the red channel. So we can see here there is an overlap of these blue cells in the FRC area. That is the first case of thalassemia, which is giving an FRC percentage of 8.7%. The next photograph is of the sickle thal case where the FRC count was 9.9 and we can see the blue dots in the FRC area. And the next one was thalassemia with 11.5% FRC count. This is in contrast with the normal scatter plot is down there where the FRC area is not showing any blue cells. So moving on to the blood pictures which were analyzed simultaneously. This is a case of thalassemia. The arrows, red arrows are pointing towards the broken RBCs which are actually indicative of schistocytes and manually these were actually counted. This is the next case of sickle thalassemia where the arrows are pointing towards the schistocytes along with the sickle cells which are shown in the picture. Then we have the cases of intravascular hemolysis. The first case is of a cold autoimmune hemolytic anemia with fragments FRC of 12.5%. Then we have MAHA, microangiopathic hemolytic anemia with FRC of 7.9%. And looking under the microscope, these are classic helmet cells and keratocytes which are triangular shaped broken RBCs or schistocytes. And this is the case of interest where in microcytic hypochromic anemia, the arrow is pointing towards the smaller poikilocytes which are actually picked up by the analyzer as fragmented RBCs, which is giving a percentage of 3.6%. And here again in the scatter plot we can see there are some blue dots in the FRC area, whereas on microscopy they were not true schistocytes but they were just smaller poikilocytes. So this is the final result of all the cases in all the 4 groups. The group 1 extravascular hemolysis, the mean FRC percentage was 2.2, whereas manually it was only 1.4%. So there was an overestimation by the analyzer. And then we have the group 2 intravascular hemolysis where the FRC percentage is 4.3 and manually we could get a mean of 3.3%. And in the group 3 microcytic hypochromic anemia, the mean FRC obtained by the analyzer was 1%, whereas manually all those were smaller microcytes or poikilocytes which were analyzed by the instrument in the FRC area as fragmented RBCs. So that is a false positive result in the microcytic hypochromic anemia group. And in the normocytic normochromic blood picture, which was a control group, the analyzer gave a mean FRC percentage of 0.3%. So this is the correlation of manual FRC versus automated FRC in group 1. This is in group 2. So the Spearman correlation coefficient is 0.933 and 0.884 respectively for extravascular and intravascular hemolysis, suggesting a good agreement between the instrument as well as the manual method of estimation of FRC. So the Mann-Whitney U-test also showed a p-value that is 0.1 or 0.4. That means there is not much of statistically significant difference between the manual as well as the automated count, suggesting a good agreement between the assessment of FRC by the analyzer and the manual method. So Bland-Altman plot for extravascular hemolysis shows most of the values which are outside the 95% confidence interval, whereas in intravascular hemolysis we can see most of the dots values are within the 95% confidence interval. So this suggests a high degree of agreement between the automated and manual FRC in intravascular hemolysis, and this is the ROC curve which is generated for group 2, that is intravascular hemolysis versus the normal group, where the area under curve is 100% with 100% sensitivity and specificity with a cutoff of FRC percentage of 0.84%. Whereas when I took the two groups together, that is extravascular and intravascular hemolysis, compared with the microcytic hypochromic anemia and the normal blood pictures, the cutoff was 0.94% with 80% sensitivity and specificity, and the area under curve was 0.86 or 86%. So what is the difference? What is the relationship between FRC percentage versus RDW-CV? This was to assess the effect of anisopoikilocytosis, which is measured by the analyzer through RDW-CV. So through RDW-CV, higher the RDW-CV, we feel the anisopoikilocytosis is more in such cases. So in the group 1, that is extravascular hemolysis, the RDW-CV was mean value was 22.1%, whereas for intravascular hemolysis, the RDW-CV was 26.9%. Whereas for microcytic hypochromic anemia, it was 19.7, and in the normal group, it was 13.5. So these are the correlation coefficient dot plots. And this is the interpretation where we can see the p-value is significant for the group of extravascular hemolysis and the group of microcytic hypochromic anemia, and it is not significant for the intravascular group. So what does this suggest? This just suggests that there is no correlation between FRC percentage and RDW-CV in the case of intravascular hemolysis. That means they are the true positive schistocytes which are detected by the analyzer. Whereas there is interference of RDW-CV. That means anisopoikilocytosis is certainly interfering with the estimation of automated FRC count in the group of extravascular hemolysis and microcytic hypochromic anemia. Then we again moved on to study the effect of microcytosis. So this is the dot plot for FRC percentage versus microcytic RBC, that is MCV. So there is, here again in the group of microcytic hypochromic anemia with MCV, there is a p-value that is significant, suggesting FRC was actually being interfered by the smaller RBCs depicted by the lower MCV. And in the group of extravascular hemolysis and intravascular hemolysis, the FRC estimation was independent of the variation in mean corpuscular volume. So again, we studied the micro R percentage. So this is another parameter that is given by the Mindray BC6200, which estimates the percentage of microcytic RBCs. So in the group 1, the extravascular hemolysis, 27.83% was the mean microcytic RBCs which were obtained by the analyzer. In the group of intravascular hemolysis, it was just 9.6, whereas in microcytic hypochromic anemia, the mean micro R was 38%. And in normal blood picture, it was just 1.2%. And these are the correlation dot plots. Moving on to the analysis correlation coefficient, there is no correlation with micro R in extravascular and intravascular hemolysis, suggesting a moderate positive correlation. And here, only in the group of microcytic hypochromic anemia, the p-value is significant, suggesting automated FRC has interference from the microcytic population. So, the other literature studies, the study by Govindrajan in pediatric HUS has showed FRC mean of 4.5% with a sensitivity of 95% in children and an accuracy of 85%. The study has suggested automated FRC as a rapid and highly sensitive index for screening pediatric HUS. However, a peripheral blood film examination is a must in cases with count of more than 2% to avoid false positive, as the index showed low specificity. And another study has again given a reference range for ADVIA analyzer of 0.3%, less than 0.3%, and for XC 0.5%. So the presence of FRC below a threshold determined at 1% has a negative predictive value close to 100% to exclude the presence of schistocytes on the blood smear, but with a poor positive predictive value. There was another study which I mentioned earlier. So this was on the Sysmex analyzer, where there was interference by hypochromasia, and microcytosis appeared to have no impact on the FRC count. And this is in contrast to our study, where we found microcytosis and anisopoikilocytosis both had interference with the FRC count. And now the recommendations of the study are: the normal range, the mean FRC percentage obtained in my study is just 0.3% for the normal blood picture groups, and we can assume less than 0.4% as the normal reference range for Mindray BC 6200. And in intravascular hemolysis, a cutoff of 0.84% has a sensitivity of 100%, and specificity of 100%. And in hemolytic anemia altogether, when we consider both intra and extravascular hemolysis, the cutoff was 0.94% with 80% sensitivity and specificity. So to conclude, microcytosis according to MCV and microcytic percentages, that is micro R percentage, and anisopoikilocytosis depicted by RDWCV showed a significant correlation with FRC percentage, suggesting an interference with automated FRC counting, and this mandates a slide review in cases with microcytosis and poikilocytosis. These are my references.
The paper is open for discussion. Any questions and suggestions or queries?
Yes, sir.
I would like to congratulate you for this nice job, but I will like that you explain us from only the CBC, what are the parameters that can trigger to diuretics to detect these hemolytic anemias in the people that don't know the patients and don't have resources as you have. From the CBC, which parameters will trigger diuretics in cases of hemolytic anemia?
So for hemolytic anemia, from CBC?
Only from CBC, which parameters will make an alarm for other places, or other laboratories to trigger
the parameters that give a clue that it could be hemolytic anemia.
Yes.
First of all, reduced HB, hemoglobin percentage is reduced. And in the BC 6200, we have estimation of the retic count, which is higher. NRBCs, which are actually given a count by the analyzer. So all of these give a preliminary hint that it could be a case of hemolytic anemia.
Thank you.
Any other questions or suggestions, comments? Talk by Dr. Rajalakshmi.
Good afternoon, everyone. I won't take much time on this. So this is another study that is being conducted in the same department of our hospital, JSS Hospital, Mysore. So here the study was undertaken to analyze the automated body fluid parameters which are generated by Mindray BC6200 in the body fluid mode. And here the question is detecting neoplastic versus non-neoplastic high fluorescent cells. That means the HFBF, that is a high fluorescent body fluid count, which is given by the analyzer, are they neoplastic or non-neoplastic cells? So what was the need for the study? The total and differential counts of nucleated RBCs, the nucleated cells in body fluids such as pleural fluid, ascitic fluid, pericardial fluid and CSF are essential to differentiate malignant effusions from reactive or infectious diseases. Many of the serous cavity effusions in infectious diseases show increased total nucleated cells and leukocytes. An accurate diagnosis of malignant cells is essential for the early diagnosis and appropriate management. And manual counting by optical microscopy is the widely used method so far for the total WBC counting as well as detection of malignant cells so far. With the advent of automated hematology analysis, we have dedicated body fluid modes. A more accurate cell counting is always possible. So the diff scatter plots along with the counting also help in identification of different cell populations based on the cell characteristics such as cell size, granularity and fluorescence. So in the BC6200 model, in the body fluid mode, this measures the nucleated cell count by hydrodynamic flow cytometry SF cube technology after lysis and fluorescence staining of the nucleated cells. These cells are classified on a 3D scatter plot according to their internal complexity, size and nucleic acid content. Additionally, this also performs impedance flow cytometry for the RBC count in the body fluids as well. So now this is the diff scatter plot in the body fluid mode that is given by the analyzer, where we can see the HFBF, that is the high fluorescent body fluid cells which are there in the uppermost area with highest lateral fluorescence and low side scatter. And then we are seeing the mononuclear cells, polymorphonuclear cells comprising of the eosinophils as well as the neutrophils. So the total count TCBF generated by Mindray BC6200 has the total nucleated cells which includes the WBCs as well as the HFBF, that is the high fluorescent cells, polymorphonuclear cells which includes the lymphocytes and neutrophils and the eosinophils, mononuclear cells which includes the lymphocytes and monocytes. So the HFBF cells are comprised of the mesothelial cells and malignant cells both. Whereas malignant cells show highest forward and side scatter with high fluorescence, these should be easily identifiable in the diff scatter plot. So what was the objective of the study? To interpret this diff scatter plot for identification of neoplastic high fluorescent cells, malignant cells versus the non-neoplastic high fluorescent cells, which could probably be mesothelial cells or macrophages. So the present study was undertaken in the Department of Pathology, JSS Medical College. Body fluid samples received in the pathology department were analyzed for cell count and cell type using Newbus chamber and automated analyzer. The differential count and typing was performed on the stained slides H&E, PAP and Leishman. The manual cell count and type were studied with simultaneous interpretation of scatter plots obtained by the autoanalyzer. And these are the results. In the past 4 months, we have run around 126 cases of body fluids. And in that, transudates or just inflammatory effusions without any neoplastic cells comprise 119 cases, whereas 7 cases were of malignant effusions. And in that, we have a true positive of 4 cases, where all the 4 cases which were proved to be malignant on microscopy have shown the malignant HFBF cells in the cell analyzer, whereas 3 cases are false negative, where there were malignant cells on the microscopy, but these cells were not picked up by the analyzer. And there are 6 cases of false positive diagnosis or flagging for HFBF cells on the analyzer. So now this is the first case of true positive, which was a 54-year-old male with ascites, and we have a HFBF count of 33.3%, and the arrow is showing pointing towards the HFBF area of the Mindray BC6200. And this is the microscopy where the tumor cells are in dispersed population rarely in clusters, and these cells show high NC ratio, hypochromatic large nuclei, high NC ratio, and this is very much positive for metastatic adenocarcinoma. So this is a case of true positive. And this is a 28-year-old female of peritoneal fluid analysis, patient with ascites. And here again the HFBF cell percentage is 37%. And the HFBF area is showing good number of cells. And this is the microscopy where we are able to see the dispersed malignant cells as well as a big cluster towards the lower area. So this patient was again positive, detected both by microscopy as well as by the analyzer, again a true positive case. So now this is another case of 42-year-old female, pleural fluid, where the HFBF was just 2%, and the arrow is pointing towards some cells in the HFBF area, whereas on microscopy, there are good number of sheets and clusters of pleomorphic tumor cells positive for malignancy, but these were not picked up by the analyzer. There is a next case which is almost similar to the previous case, where the HFBF area is showing good number of cells, but the HFBF percentage by the analyzer is just 1.6%. And this is the microscopy. Again, here it is showing no dispersed population, but good number of sheets and clusters of malignant cells. So now this is another case of false positive. That is, there are no malignant cells on the microscopy, but the HFBF is flagged by the analyzer of 35%. And on microscopic examination of the stained smears, there were no malignant cells, and these were all reactive mesothelial cells. This is another case of false positive diagnosis. And here again, HFBF is 26%. And on microscopy, we are only seeing inflammatory cells and macrophages. There are no malignant cells. So now, there are studies on the automated analyzers in the body fluid mode, where BC6800 has been studied in the body fluid mode. And here the suggestion is, it offers a rapid and accurate cell count and differential count in clinically relevant concentration ranges. The use of this analyzer may allow to replace the routine optical counting, except for samples displaying abnormal cell counts or abnormal diff scattergram. That means wherever there is an abnormal count or an abnormal scatter plot, we have to manually verify the smear. There is another review by Martin et al. Which has suggested a systematic qualitative review of the differential scattergram and the HFBF count in Mindray analyzer to enable the development of algorithms that help determine whether microscopic review is indicated. So these were the literatures that were available. And here to interpret in my study, why there were false negative cases which were analyzed on the Mindray analyzer. One, both the cases, all the three cases actually of false negative diagnosis by the analyzer had tumor cells in cohesive clusters. And this was probably because of the difficult permeability of the fluorescent dye, and these cells are not picked up. And then these clusters probably are not analyzed by the analyzer, because they find that the cells cannot pass in single file for the hydrodynamic cell focusing. So these are the two difficulties which are being encountered in the present study, and the study is still continuing because it is part of the dissertation. So the conclusions here are probably a separate gating for the high fluorescent malignant cells that can separate the macrophages or the mesothelial cells from the malignant cells would be helpful. And then there could be a method where we can come up with some analysis or some way of dissociating the malignant tumor cells which can pass in single cells, and the analyzer will be able to better analyze the morphologic characteristics of the cell and put them in the high fluorescent area. So this is the, those are the first two cases which are of true positive, and then the below, the red circle is pointing towards the HFBF area in the false negative cases. So I want actually the input from the people who are present here to solve this particular issue, and especially Dr. Ramon Simmons, sir.
Dr. Rashmi, it's a very good presentation. I mean, it's very difficult to answer because very obviously the malignant cells are very clearly seen in the fluid.
Yes, sir.
Probably pre-analytical, this one you have to see whether there was a lot of gap between the collection and the sample the way when it reached our lab and what is the time gap, maybe that is number one. Number two, as you mentioned, because of the tight clustering of cells, the fluorescent dye would have not reached the cells. And number three is there any method by which those malignant cells can be a little bit dispersed and then they can fed into this one. It's a very good study, I think, is for the technical people to improve upon their analyzers, I think.
Well done.
Thank you, sir.
I think there is a question, Dr. Rajalakshmi.
What I feel is regarding mesothelial cells, they are very dynamic cells, so there's a lot of range in the size of this cell. So even if we dissociate them from clusters, what we see in cytology is they range right from maybe 10 microns to even 150. So even if we gate or we develop something, the nuclei and NC ratio are highly variable. Nuclear size is highly variable. So none of the parameters which will gate them, because they are not having granules, so complexity cannot be measured. So it will always give you a wider range and it will put them randomly into different groups. Even they can come in WBC groups if they are tight and small in size. So it's not going to change our routine smear examination. Because if they are in clusters and we rely on this, we may miss malignancies, especially in the setups where alternate fluid is coming to rule out malignancies.
May I know the criteria of slides viewing?
May I?
Because generally what we see, the total count and the WBC count difference is there. So have you set a cutoff between there is a major difference, then only we'll see the slide, or just a few cell differences there, then no need to see the slides?
Madam, actually the study is still ongoing. This is only a preliminary study interpretation which I have just presented here. I was mainly worried about the false negative cases which were given by the analyzer. Cutoff has not yet been established. It is not yet analyzed, ma'am. I still have the study that is on.
Because fluid is analyzed in the clinical side.
And so far, for all the cases, we are doing a smear review as well as a comparison of the automated and the manual count for all the cases.
If the total count in WBC is matching, no need to see the slide, right?
Madam, we actually screen all the slides just to find out if there are malignant cells or not. That is the main intention of screening all the smears, all the cases.
Okay, thank you.
May I call upon stage the next speaker, Dr. Archana M. And may I request Dr. Prashant Gupta to chair the session, please.
Dr. Archana M has done her MD in pathology from JJ Medical College, and her area of expertise is oncopathology, and she has done fellowship from Kidwai Cancer Institute. She is passionate about the teaching and she has many articles. I request her to start the session.
A very good afternoon to one and all. So I am very happy to present this study which was conducted in our department. So the title was Predictive Ability of Reticulocyte Hemoglobin Content for the estimation for low serum iron. So we have the Mindray BC 6200 instrument in our laboratory. So reticulocyte hemoglobin estimation is the measurement of hemoglobin inside the reticulocytes. It correlates directly with the functional availability of iron in the marrow, and RHE may be used in lieu of serum iron if we can demonstrate a significant predictive ability in the diagnosis of iron deficiency anemia and for the follow-up after initiation of iron therapy in patients with iron deficiency anemia. So the aims and objectives of the studies were as follows. So the primary objective was to determine the ability of RHE in predicting low serum iron, and the secondary objectives were to obtain a correlation coefficient between the RHE and the serum iron and also with that of different RBC parameters. The study was a prospective analytical study conducted in a tertiary care hospital over a period of 3 months. Patients who were evaluated for anemia with serum iron were recruited and the reticulocyte hemoglobin was estimated. Patients who had already received iron supplements and pregnant women were excluded from the study. A sample size of 250 was statistically suggested. Numerical variables were summarized as median and interquartile range, and categorical variables were summarized as proportions. A comparison of the median was done using the sign test. Spearman correlation coefficient was used to estimate the strength of correlation between RHE and low serum iron, and we proposed a cutoff of less than 50 micrograms for iron deficiency anemia. And the cutoff value for RHE was obtained after plotting an ROC curve. So moving on to results, 250 cases were studied. The median age of our subjects was 41 with an interquartile range of 20 to 59 years. A female predominance was noted with 58.8% of the study population constituting females. Of these 250 cases, 180 cases had a serum iron of less than 50 micrograms, which fulfill the criteria that we have set. So as we can see here, an ROC curve was plotted to obtain the cutoff value of RHE for the diagnosis of iron deficiency. A value of 22.7 was obtained, which had a specificity of 95% and a sensitivity of 72% for the diagnosis of iron deficiency. Patients with low serum iron, the RHE was 16.2 with an interquartile range of 15.2 to 17.3, whereas the median RHE for patients with normal serum iron was 26 with an interquartile range of 22.2 to 30.6, and this difference was statistically significant with a p-value of less than 0.01. Here again we can see a correlation scattergraph and histogram of RHE against serum iron, and clearly we can see that low serum iron values correlate with low RHE levels. On comparing RHE levels with other RBC parameters, we found that the highest correlation was seen with MCH, and it also had significant correlation with other RBC parameters, all of which except for the RBC count. The correlation coefficient of RHE with low serum iron was 68%. The same thing is tabulated here, and as we can see, the best correlation was obtained with that of MCH, and there was no correlation that we saw with that of RBC count. Moving on to discussion. We know that reticulocytes are younger stage of RBCs with a lifespan of 24 to 48 hours, and hence they are more sensitive to iron deficiency, and they help detect iron deficiency anemias earlier than that of iron studies. And RHE is now found to be increasingly recognized to be of utility in identifying iron deficiency at an early stage and as an early marker of response to treatment. Our study further helps strengthen understanding the role of RHE content in iron deficiency anemia. So to conclude, RHE has an excellent correlation with low serum iron. It also correlates well with other RBC indices except for the RBC count. RHE value of 22.7 picograms has good sensitivity and a high specificity in diagnosing low serum iron levels. These are my references. Acknowledgements, I would like to express my gratitude to the entire department of pathology, the staff, technicians and postgraduates of JSS Medical College. Special mention to Dr. Vani K, Dr. Sheila Devi, our HOD, and Dr. Manjunath Sir, who's our Deputy Director. Special thanks to BLK Max and Mindray and all the organizers of CUBE HDMI 2023. Thank you. I would just like to add one point, and I think after listening to the talk that has happened since morning based on the reticulocytes and its parameters, after listening to Dr. Ramon and Dr. Manoj, I think we'll have to go back and also look at the inflammatory parameters and then have a better correlation, sir.
No, I think the study is perfect because the situation is the patient have iron deficiency.
Yes, sir.
But both have iron deficiency. Anemia of chronic disease have an iron deficiency.
Yes, sir.
And absolute iron deficiency have also iron deficiency.
Yes.
The situation is both have low serum iron, low transferrin saturation.
Yes.
But is there any deposit of iron? This is the question.
Yes.
And this is the question only for the treatment.
Yes.
For the diagnosis is perfect. For the treatment, depending of the inflammation and if to know if the deposits of iron are full or not.
Yes.
Or are empty. But the study is perfect. No any complaint for this study. Fantastic.
Yes. Thank you.
You can follow up this study for the response of red hemoglobin for with the treatment. Response, how it is responding.
We have not got the follow-up data because majority of the patients tend to come on an outpatient basis and take treatment and get back, sir. So we will try to do a follow-up also in the further studies, sir.
Yes. Dr. Archana, she has done her MD from JSS Medical College, Mysore. She has participated in various state and national conferences, has presented many papers. And area of interest are oncopathology, nephropathology, cytology and medical education. She will be talking about platelet comparison in platelet I and O in the presence of platelet mimickers. Over to you.
Thank you, sir, for the kind introduction. Good evening, everyone. It's over to the platelets again after so much of discussion about the various methodologies that are used to determine accurate platelet counts. My studies on comparison of platelet counts analyzed using impedance and optical principles and automated hematology analyzer that we have in our lab and in the presence of platelet mimickers. So as we all know, assessment of platelet count, that is accurate platelet count, is very much essential because the deficiency or defect in their function may lead to fatal bleeding, and it's also essential in disease monitoring as well as treatment. Finding a reliable method to determine an accurate platelet count remains controversial till date, and the commonly adopted principles are that of optical density and electrical impedance. So in the conventional impedance method, the platelets and the RBCs can be distinguished by the magnitude of electrical impedance signals in normal samples. It is subjected to the interference with microcytic RBCs, fragmented RBCs, as well as large platelets when it is used to differentiate platelets by cell volume. Microcytic RBCs and fragments will falsely elevate the count due to the interference of the RBCs, and in presence of large platelet and platelet aggregation commonly found in thrombocytopenic samples, it may be falsely low. So the study aimed to determine the accuracy of the optical density and the electrical impedance methods in determining the true platelet counts in thrombocytopenic samples and in those samples with microcytosis. So a retrospective analytical study was conducted in our hospital. The various CBC parameters were obtained from the LIS and platelet counts were tested using both the optical as well as the impedance methods. Patients with thrombocytopenia, that is count less than 1,50,000 were considered, and MCV less than 70 femtoliters was considered as a cutoff. The study was conducted over a 3-year period, and patients with normal blood counts were taken as controls. All the qualitative data were analyzed as median with interquartile ranges and categorical data analyzed as proportions. Correlation of continuous variables was reported as Pearson correlation coefficient, and agreement between two continuous variables which measured the same parameters were done using the Bland-Nanman analysis. A difference of more than plus or minus 5% between the two methods was considered statistically significant, and we had a total of 398 subjects included in our study. So these were the various parameters that were analyzed, and these were the cases of microcytosis with the median MCV being 63 and cases of thrombocytopenia with MCV being almost normal and platelet count with a median range of 1.01. So the platelet count was higher in 48% of the patients by optical method and only by 2% by impedance method in control subjects. Presence of microcytes resulted in higher platelet count by impedance method in 18% of cases. And in thrombocytopenia, also the impedance method had its own disadvantages. So when the Bland-Altman analysis was plotted, the coefficient of variation between the controls as well as the impedance method, the optical and the impedance method in control subjects exceeded by 5% in 33.7% of the cases. In microcytic anemia, the two methods, between the two methods, there was about 24.3% of cases which exceeded the 5% cutoff. And in cases of thrombocytopenia, the coefficient of variation between the two methods exceeded by 5% in 41.8% of the cases. So there still remains a debate as to which method is more suitable for platelet counting, especially with platelet interference like microcytes and in cases of thrombocytopenia. Platelet count by impedance method resulted in higher platelet counts in the presence of microcytes, and overestimated platelet counts in samples of with MCV less than 70 femtoliters. So to conclude, the presence of microcytes as well as thrombocytopenia result in significant alteration in platelet count by the impedance method. So a platelet H is a new parameter that Mindray has come up with, and it generates a graph combining the impedance channel as well as the diff channel parameters. So these are the graphs that are obtained, that is the platelet I and the diff channel. In the diff channel, the RBCs are lysed and hence the large platelets are detected. Now combining the two graphs obtained from the impedance channel as well as the differential channel, the platelet H is generated. Now this is another parameter that needs to be explored, and it's available on the Mindray BC 700. So we are yet to explore that. These are my references. My acknowledgements to all the professors in the Department of Pathology. Special thanks to Dr. Vani, Dr. Sheila and Dr. Manjunath for this opportunity. And of course, Mindray and BLK Max for the opportunity for presentation on this platform. Thank you.